Policy Board and will facilitate today's meeting. The Zoom chat feature in today's meeting only allows meeting attendees.
I found this on the web for what's the chair.
The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host or co-host or emailed to the Oregon Health Policy Board at healthpolicybord@dhsoha.state.or.us. All materials for today's meeting are available on the Oregon Health Policy Board website and hyperlinked in the meeting materials column of today's agenda. Let's go ahead and get started with a roll call. Tara?
All right, Oscar Arana.
Here.
David Bangsberg.
Here.
Ebony Clark.
Here.
And Jessica Gomez, just let me know she's going to be a couple minutes late. So we'll move on to the next person. Kirsten Isaacson.
Here.
And we have Brenda Johnson absent today. Bill Kramer.
Here.
Sandy Sampson. I'll connect with Sandy to see if she's on her way. John Santa.
Here.
All right. Thanks, everyone. Looks like we have one absent today.
Hello.
Oh, I think that was Sandy.
Yeah, I'm here.
All right, Sandy, thanks. All right, looks like we have Brenda absent and Jessica on the way. Everyone else is here. Thank you.
Great, thank you, Tara. So I just want to remind everyone that today is David Bangsberg's last Oregon Health Policy Board meeting. We all had an opportunity to thank him and say farewell for his many years of service during last month's retreat. I just want to acknowledge again how fortunate we've been to have David's talents, skills, and experience on the board. David, you've guided the board and the agency through some very challenging and critical times, and you always demonstrated patience, kindness, wisdom, and a strong commitment to improve health systems. We will miss you on the board, but please make sure to keep us posted on your California adventures. I'm going to provide a quick overview on what we'll cover today. First, Director Allen will provide an agency update. And then our second item is a presentation of the Medicaid Advisory Committee on improvements to the consumer experience. Following the presentation, we'll discuss their proposed recommendations, and there will be a request to support their recommendations. Staff with the Health Information Technology Oversight Council will provide an update followed by a request to approve its proposed slate. We'll take a break and hear public comments if there are any. Staff with the Sustainable Healthcare Cost Growth Target Advisory Committee will present its proposed slate for our approval, which will also require a vote. And then we will spend the rest of our meeting debriefing last month's retreat. So, and just to give a heads up, any item that's going to require a vote, I'll go around and ask all the policy board members for their thoughts before taking that vote. So our first order of business is to approve the March 1st meeting minutes. A copy of the minutes is included in the attachment and is posted in today's agenda and on the Oregon Health Policy Board's website. Can I get a motion to approve the March draft meetings?
This is Ebony. I move. Oh. Or I'll second.
Thank you, Ebony and Kirsten. All those in favor say aye.
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 Anybody opposed? All right. Let's keep moving. All right. Director Allen, we know you joined us last month for the retreat, but we didn't get an opportunity to officially welcome you back to work. So we're so glad to have you back and to have you with us today. Go ahead and provide your update.
Thanks, Chair. I'm certainly glad to be back and with you all. A couple of things to talk about today. First, let me give you a little bit of an update on the pandemic. I say pandemic. Yes, we are still in a pandemic, despite the desperate desire of many of us to believe otherwise. We are now in our seventh surge of the pandemic. And I want to say a few things about the numbers, because the nature of the numbers that we've all been tracking over the last couple of years really have changed quite a bit. Right now, our case numbers are edging up. We're reporting now typically on weekdays when we're getting full reporting well more than 1,000 cases a day. We're about 6 weeks into this surge, and those case numbers have become increasingly unreliable. I think they're useful in terms of directionality. We're certainly seeing more COVID this week than we were last week, and more than the week before that. But to compare the number of cases today to previous surges, I think is highly problematic. Throughout the pandemic, we've known that we're only capturing a portion of the cases out there in officially reported and diagnosed cases. Up until the Delta wave, our best guess is, depending on how big the wave was and how much testing there was, anywhere from probably 25% of cases, maybe as high at some points as high as 50% of cases. Nationally, there was some research during the Delta wave that indicated diagnosing 1 in 4 cases was a pretty reliable indicator. That got more problematic during the Omicron surge because of the sheer volume of cases. But now during this 7th wave, with the Omicron subvariant wave, we're really impacted by the prevalence of at-home testing or just unwillingness to test at all, which has become much more common. And so estimates out there range from that Omicron rate of diagnosing about 1 in 4 cases to perhaps as few as 1 in 10 cases. And so that number of cases is much less reliable. More reliable are things like hospitalizations, ICU utilization, fatalities, which all lag to some degree. Hospitalizations have a shorter lag than they did early in the pandemic. They're also complicated by the fact that, based on OHSU's best estimate, probably half of hospitalized cases today are what we call incidental cases, people who are in the hospital for some other reason and happen to test positive for COVID. Now, that's not without cost to the healthcare system. Those patients still need to be treated in isolation. It's more burdensome for staff, more consumptive of PPE and all those kinds of things. Numbers that I'm looking at, really focusing on in terms of severity, would really be the ICU utilization and the number of people on ventilators. Previously, the lowest we ever got to the number of Oregonians on ventilators with COVID was somewhere in the 12 to 15 range. A couple of weeks ago, we were down as low as just 1 person in the entire state on a ventilator. Right now, that number has trended up, as all the other hospitalization numbers have, but not nearly as dramatically as those case numbers have. The other number that I've been keeping an eye on that doesn't lag quite so much is the percentage of people showing up in emergency departments with COVID-like symptoms. That's short of a diagnosis, but again, that's a number you can track over time to see where we've been. That number's gotten up as high as 10% during the 6th wave, the Omicron wave. And right now we've been hanging in around between 2.5% and 3% of people showing up at an emergency department having COVID-like symptoms. All of that gives us, I think, some reason to believe that all of the predictions still remain on track, that while we may well see lots more cases, we're beginning to see a divergence between cases and severity. And so a large number of cases in this surge may not present the same kind of a stress on the healthcare system that previous surges have. I think we've still got some time to continue to watch that, but I'm encouraged so far that appears to be the case. In terms of response, we're continuing to do basically the same kinds of things we've done, with a shift in focus in terms of testing, vaccination, those kinds of issues. We're really focusing on vulnerable populations, trying to work on improving booster rates in congregate living, those kinds of areas, improving second vaccinations and booster rates in communities of color. Other areas where we know outcomes tend to be worse if we don't tend to those issues. So that's really kind of the status of things as we sit right now in terms of the pandemic. I said we're 5 or 6 weeks in. Most of the surges have taken about 2 months to get from the beginning of the surge to the peak, and then the length of time from the peak has been pretty variable depending on the surge. So we're maybe a bit more than halfway toward the peak of this surge, if this surge follows that same pattern. Of course, it's impossible to know if that's actually going to play out. Second thing I'll talk about briefly is Measure 110 implementation. I know that's not been a prime topic for the board, but it's gotten a lot of discussion and notice around the community. It's been a challenging implementation for a variety of reasons. We're continuing to reallocate staff from all over the organization into kind of project management and oversight of that work. We are now completing the first phase, which is to assess the 333 applications that were received for providers who wanted to be part of behavioral health resource networks against a robust set of rubrics to assure that they were able to provide those services. That work is completing and the council should make its final decisions with respect to most regions within the next week and a half, I believe. That then moves us on to the next stage, which will be complex, which is negotiating memoranda of understanding for those behavioral health resource networks across 36 counties. Some will be fairly straightforward. Those will be in smaller, more rural areas where the number of providers is pretty limited, or there's just a single burn, as we call them, for a county. Baker County is a great example. It'll be much more complex in larger counties where there are multiple burns and multiple providers in those burns. We're doing what we can to provide template memoranda of understanding, contract agreements, all those kinds of things, so that if regions choose, they should be able to go ahead and take those documents and move forward with them and be able to get funding. Others will choose to negotiate those separately, and that'll take longer, and we're working to facilitate that work as well. I see Sandy Sampson has a hand up. Sandy?
Sorry. Yeah, Pat, I just was curious, self-testing versus, prior to, I just don't think maybe sometimes the numbers are, accurate. Are people, actually coming forth and saying they've got COVID? Because now, you think the trend is, I can't miss work because I don't have COVID leave, and they're going to work instead of not. I'm just wondering if you've seen any trend in self-testing, people actually calling OHA or going in to get a second test. I guess that's my biggest concern. I know we have very little COVID cases, but we've got a lot of self-testing, so I don't think people are reporting it.
Yeah, no, I think that's right. I think we have known, and we've been candid about the fact that the case count has been an undercount throughout the pandemic. I think that undercount has gotten worse because of home testing. We do have a reporting mechanism online or by phone for people to let us know that they have tested positive. There's not a retest requirement or anything like that that goes with that. And we do have people who are reporting in, but we believe that it's a pretty significant minority of those who are testing at home, both positive and negative. And so, as I indicated, I think other than direction, cases are going up. That case number is increasingly unreliable as an absolute measure of cases. And the other data points that I talked about around hospitalizations, ICUs, fatalities, symptoms at the ED become much more useful, and looking at them all together. Positivity rate, I'm sorry, that's another, although that's got some challenges now with self-reporting as well. Those together all become much more useful. Chair Arana, I was done actually with what I wanted to say about Measure 110, so maybe I should turn it back to you to moderate other questions, since it looks like we've got a line.
Sure. Jessica.
Can I have just one quick comment? So I really do like your your QPR code for your testing. Your personal electronic COVID-19 vaccine record. So I just want to give you kudos for that. That's great. Thank you.
Good, thank you.
Jessica?
Yeah, so I've been following the situation with the Measure 110 dollars, and my question is, why the holdup? Why is this taking so long to get these dollars out? Why weren't we better prepared? I mean, we've known this was coming, and you know, in my opinion, and we've got now the drawbacks of Measure 110 and none of the benefits, and people are really struggling out there. What is the reason why it's taken so long to get this out of OHA and into communities to help people?
Yeah, thanks for the question. It's a complex answer. I'll try to be brief with a summary here. You know, I think it's tempting to think that what Measure 110 does is reallocate money from one purpose to another purpose and put that money out for treatment. It does that, but the other thing that it asks for or requires is really a complete reinvention of that treatment delivery system. I think what it acknowledges is the fact that in the pre-Measure 110 environment where addiction was effectively criminalized, the treatment system available to people who are no longer incarcerated for their addiction isn't adequate to that work. And so it asked us and the independent advisory council that has absolute decision-making ability over this work to completely reinvent that system. And I think the timelines were overly aggressive to be able to complete that reinvention. I think we at OHA compounded the problem by I think being overly sensitive to that reallocation of power to an advisory council that really didn't have, and they themselves have said, didn't have the background in grant making to be able to effectively do that part of the work. And so I think we share responsibility for that piece. But I think the challenge, the job in front of us has been really monumental and is really important and valuable, and will see good results once we're able to completely reinvent the system. But you know, the fact of the matter is what the measure essentially said is it's fast to get money out to the providers who are already providing these services, but that's not necessarily the right set of providers or the right system or the right networks of providers working together to be most effective for this population that's not been well served historically by that existing system.
I mean, I understand the complexities of, you know, making some changes to the system, but again, you know, there was time there. It's not like this just popped out of nowhere. And it just seems like, again, and I don't know, because this is the first time I'm really hearing about this at the policy board level, but you know, to hear about some of these failures in the news and to get phone calls from people that are struggling with this, I'm sorry, like that is not that's not an effective system, and I really think we should have done much better. Just wanted to express my concern, and we really have to get this up and running.
I appreciate that. Thank you.
Ebony?
Oh, yeah, thank you, Director Allen. You know, and I just also want to say that I do appreciate the question, Jessica, and Director Allen. I appreciate the transparency and the accountability. And, you know, I know that, you know, different tables, there's been conversations too, kind of at the executive level of OHA around lessons learned around this as we move forward and as we start to think about, you know, really kind of being more community driven. You know, what does that mean and how do we leverage the voice and then translate to kind of the system infrastructure. So I think there's a lot of good lessons learned. But my question was wanting to know, with kind of the current surge, are statewide, are we seeing the similar trends in some of the BIPOC community as we were in prior surges, or not really?
Yeah, I think I would want to more completely look at the data to give you a fuller answer. But my quick answer is the disparities have narrowed from early in the pandemic. Now, I think we've got sort of an interesting geographic thing going on in this round, and this is true nationwide. If you look at statewide data, the more highly vaccinated counties tend to be having higher rates of cases, again with the big caveat of the accuracy of those case numbers, and so that causes you to ask the question, well, why is that? I think there are a couple of potential reasons for that. One is the willingness to test. I think what we have seen is a testing bias that tends to track with areas that are more likely to be vaccinated. If you're more likely to be vaccinated, you're more likely to wear a mask. We've certainly seen that data. If you're more likely to be vaccinated and wear a mask, you're more likely to test following an exposure or with symptoms. And so we're seeing more cases because there's more testing going on. I think the other potential factor is waning immunity, both exposure immunity and vaccination immunity, as I understand it, wane over time. And because of the Delta and especially the Omicron surge, immunity from exposure is more recent than immunity from vaccination, which occurred earlier as we got out volumes of vaccination. So we may be seeing some differences there in terms of the length of time. Now, I bring all that up because it also has an impact on which communities are most exposed to higher rates of transmission. I think that's going to be especially true in the African American, African refugee communities, those kinds of things. Maybe less true in Latino communities, depending on geography. So that's why I want to hedge my bet a little bit in terms of disparities. But in general, they've been narrower, and we know also that we've got now a complete lack of disparity in vaccination rates amongst Black Oregonians, American Indian, Alaska Native Oregonians, particularly, and that's helpful as well.
John.
Yeah, Pat, thanks so much. I'm just wondering thoughts about a fifth shot, a fifth or a third booster. I mean, I see a lot of discussion, relevant to your previous comments there about waning immunity and again, in older populations, I think they're representing a bit higher percent of cases. I'm sure there's going to be thoughts about when do we get a next booster, and do we wait for the Omicron? What's your sense of that?
Yeah, so I have not heard if a fifth shot or third booster, just to catch everybody up. Of course, the basic course for the non-Johnson & Johnson vaccine is 2 shots. That basic course includes a third shot as part of the complete first course for people who are immunocompromised. That's an additional dose, not a booster, strictly speaking. And then a booster has been recommended for everyone 12 and above, and for everyone 50 and above, a second booster is recommended. That would be four total doses, and you're talking about a fifth dose. I've not seen a lot of discussion about a third booster or a fifth dose at this point. What I am seeing is a fair amount of discussion about reformulation, further vaccine research, a sense generally, I think, that we're heading toward a COVID vaccine, ideally looking more like a flu vaccine with a periodic reformulation and an annual kind of a dose. But I think the important part right now is that the vaccines continue to be extremely effective at keeping people from becoming seriously ill or dying from COVID. And the data on boosters, sort of as you go down the line, seems to get weaker over time. And I think that's the struggle that's going on right now in the scientific community around how to best manage that process.
Jessica?
Yeah, so my question is around data for some of this. We have a lot of people that are now vaccinated, boosted. We were also masked up until recently. Do we have any data around people who were vaccinated but then were unmasked, just sort of getting back to what you would say, sort of typical activity in groups and all this, versus people who were more isolated? Do we know, do we have any comparison data as to rates of infection after those boosters? In that way, whether or not, people were isolating at home more often, or if they were sort of, out and about, going to concerts and, other types of things.
Yeah, so in Oregon, we don't have controlled, I mean, the problem is this is a multi-factor problem, right? You've got waning immunity, whether from vaccination or from exposure. You've got increased social mixing, whether in crowds or grocery shopping or whatever. You've got a change in masking, that there's good data both for people who are vaccinated and unvaccinated to be less likely to be wearing masks. In Oregon, we don't have any controlled data that would let you tease out of those individual factors which are contributing. The general understanding globally around this is that are some of each of those factors that are at play, plus the increased infectivity of these Omicron variants, and they're all contributing to this most recent wave, offset partly by potentially less virulence of the variants, plus the benefit of fairly high rates of vaccination, as I said before, still being quite effective at holding down rates of serious illness and death. But I don't think there's any data that we can point to, certainly that we manage in Oregon, that would let you say which factor is contributing how much, if that's what you're getting at.
Yeah, are there other states or other sources of data to do that comparative analysis?
I'm not aware of a sort of a comprehensive data set that would do that. I know that there is active research going on around the world around some of those questions, but I've not seen results of any of that yet.
Thank you.
Director Allen, I know you have to get going to your 9 a.m. So we'll let you go. Thank you so much for presenting today.
Thanks, and I should be back about 9:30.
Sounds good.
Thank you.
All right, so next, I want to welcome Leslie Huggins and Lavinia Goto with the Medicaid Advisory Committee. OHPB members had the pleasure to meet with both of you last month before the retreat in the member small group breakout discussions. It's nice to see you again. Thank you for being here to present the Advancing Consumer Experience Medicaid Advisory Committee Subcommittee Recommendations Report. Go ahead and begin when you are ready.
Hey, Jackie, I think you were going to kick us off.
Sure, I'll start with the first few slides. Good morning, everyone. I'm Jackie Wetzel. I'm part of the Transformation Center at the Oregon Health Authority. I'll start with a quick overview of the Medicaid Advisory Committee and the background of the subcommittee before turning this over to our MAC co-chairs, Leslie Huggins and Lavinia Goto, who will cover the subcommittee findings and recommendations. If you would please hold your questions till the end, we do intend to leave roughly 10 minutes for discussion, and we're trying to get through the slides pretty quickly. So with that, if we could please advance the slides to slide 3. The MAC, the Medicaid Advisory Committee, is required by both federal and state statute and advises the Oregon Health Authority and the Health Policy Board on the operations and policies of the Oregon Health Plan from a consumer and community perspective. The MAC includes up to 15 governor-appointed members, and members bring many different perspectives to the group, including those of providers, advocates who work with OHP members across the state, representatives of CCOs and other healthcare organizations, and importantly, OHP enrollees. The MAC is currently focused on monitoring CCO 2.0 implementation from a consumer perspective, reviewing the 1115 waiver renewal from a consumer perspective, and several MAC members are directly involved in the work of House Bill 4035, including serving on the Bridge Program Task Force and on the Community Partner Outreach Work Group. Next slide, please. So a little bit of background about the subcommittee. The subcommittee was formed in late 2020 to listen to and understand the challenges of OHP consumers. And as much as possible, we really like to hear those challenges and experiences in the words that OHP enrollees use to describe them. So we listen to challenges and experiences, and we identify improvement opportunities. And some of the issues that MAC members were aware of and that led to the formation of the subcommittee are challenges that arise when benefits are siloed across multiple agencies, when care coordination responsibility is unclear or roles are shared by multiple organizations, or challenges due to complex medical or psychosocial needs. Next slide, please. So today the MAC is here seeking the policy board's endorsement of the subcommittee report and recommendations. The basis of consumer experience work is really empathy. And as we move through these slides, we ask that you think about your own healthcare experiences. How are your experiences with healthcare similar to or different than the experiences that are shared by OHP members? And also think about how the non-clinical parts of healthcare, so for example, enrollment in benefits, system navigation, communication, how do all of those activities impact access to healthcare services and ultimately equity? With that, I will turn it over to Leslie.
Good morning, everyone. I'm Leslie Huggins. I am a pediatric dentist for Capital Dental Care. I'm the dental director for outreach, and I am the oral health member of the MAC. And so thank you for being here this morning. We spent the first 3 months listening to subcommittee members share experiences, and we were trying to find sources of direct OHP consumer input from populations across the state. And one of the ongoing limitations of this work is that there is inadequate access to unfiltered consumer voice. The consumer stories that we heard are all important. However, findings may not be representative of the more than 1.3 million people enrolled in OHP. And there may be other common challenges that did not surface in this work. One of our recommendations seeks to address this directly. Next slide. There were 4 clear themes that emerged from the information that the consumers shared. The first one, common communication challenges, included finding information that was easy to understand, as well as understanding information from various healthcare organizations. And we're going to walk through a few short examples in the following slides. The second one was care coordination. These challenges included access difficulties, for example, requesting care coordination and being told that these services are not available, as well as a lack of awareness or understanding of what care coordination is. The third one was transitions in care or in benefits were a frequent source of challenges, with missed opportunities for planning and preparing to preserve access and achieve optimal outcomes. Next slide. We'll walk quickly through a few examples to illustrate how members experience our complicated healthcare delivery system. And this slide shows how benefit information is presented to consumers, which requires decoding various acronyms to make sense of it. So that is difficult in of itself. Next slide. Also, provider search tools are a frequent source of frustration, and this is an access barrier. Now, the list on this slide is from one search tool that includes a list of more than 200 different options for provider type, many of which do not seem to be geared towards consumers. These categories may be useful to someone, for example, the DCO capitated provider or the delegating NSG, but they're not designed to make sense to consumers. Next slide. Consumers also shared many challenges related to denials. These are also termed notices of an adverse benefit determination, or NOADs. On the screen are two excerpts from the same denial that illustrate these challenges. So the consumer quotes related to this include, healthcare requires learning a whole new language. That was the feedback that we got. How can I participate in an appeal if I don't know why the procedure was denied? And when you look at the bottom paragraph and you see all this series of codes, would you understand the reason for the denial? So over the past several months, OHA has made some progress, and they have worked to translate denials into plain language. This is not an easy issue, and we want to acknowledge that there are many complex requirements for information that payers must include in a denial. However, remember, the denial is for the consumer and needs to be designed with the consumer in mind. Next slide. Moving on to care coordination. Members experience access barriers to care coordination services. Sometimes they've requested care coordination and they're told that they're not offered. Members are not always aware that these services exist, and there's no standard definition of care coordination or information on about how to access the services. These two examples on the slide, if you note the overlap with both care transitions and communication. In the top quote, care coordination did not happen to support this member in the transition from fee-for-service to a CCO. And in the bottom example, the member was not aware of care coordination. And again, that's a communication problem. Next slide. Here's another example of an access issue, along with a common problem of care coordination. So trying to discharge a pediatric patient, it took 10 calls and an OHA senior administrator. Care coordinator giving the phone number. What they really need is for somebody to make the phone calls for them and help facilitate this, not receive a list of resources. They need active assistance. Next slide. So challenging transitions include moving from OHP coverage to dual eligibility. You can see these 6 challenging transitions. Note that many of these are age-related, which means they are predictable and they can be planned for in advance. Next slide. Here's a few quotes from consumers about challenges with care transitions. Now, none of these should have happened without first developing a plan with the consumer, which would minimize or prevented service disruption. And from a consumer perspective, they are often left in the dark about what will happen or lose services and benefits suddenly without adequate planning. Next slide. And a couple of other examples. Families are left to start from scratch to find adult providers willing to treat young adults with disabilities. And then another one where an individual had lived in adult foster care or adult foster home for 12 years, but because they developed a behavioral health condition, that home was not equipped to support the behavioral health needs they had. So we are thankful to be able to provide this information. And at this time, I'd like to turn it over to Lavinia, who is going to provide and discuss some recommendations. Thank you for your time.
Thank you, Leslie. My name is Lavinia Gocho, and I'm co-chair of the Medicaid Advisory Committee. I have actually my day job, if you will, is I'm a project manager for long-term care innovation with Northwest Senior and Disability Services, which is an area agency on aging. So our first recommendation Thank you. Our first recommendation has to do with the communication piece that Leslie already highlighted. What we're recommending is that there be standards for provider search tool functionality. As Leslie demonstrated, there's a lot of confusion. It's difficult for consumers to use the search tools, and language certainly has a lot to do with it. And then develop standardized consumer-facing plain language materials, starting with denial notices. And I know there's a lot of work on this right now, and that's wonderful. Information about health-related services, flexible services, and I understand there's work in progress in that as well. And then care coordination. So you'll see a common theme throughout this whole thing about how care coordination can actually play a role with all of these our recommendations. And then allow for CCO specific details where needed, but maintain some sort of standardized experience for the consumer. And then this is key too, involving consumers in the work and co-create in multiple languages. So we want to make sure that we have consumers at the table. Next recommendation. So in terms of care coordination, again, we're asking to set clear standards for care coordination, primarily to ensure services are person-centered and accessible, and to avoid situations where folks are unable to access or even being aware of care coordination being available. So we want to be able to develop a consistent service level to OHP members statewide so that they aren't finding inconsistencies between CCOs. And then actively promote care coordination as a service that's available to all OHP members. And this will help to address the barriers to care and improve outcomes, ensure culturally and linguistically appropriate care, and support communication and transitions across providers, settings, and time. And I think that you already saw some examples of that. And that actually takes us to the next recommendation regarding transitions. To improve transitions of care across systems, for example, CCO to CCO, or when the consumer's health or social needs change. And require that the plan be in place before the transition happens, because many of these are very predictable. Youth will age out, and so we know when that happens. So it's very predictable. Youth who transition to adult services, and adults who become Medicare eligible. So then maybe they change, or they transition from Medicaid to Medicare, or Medicaid to Medicare and Medicaid as a dual. And then when moving from one CCO to another, or from fee for service to a CCO. And then when service needs change, I think the example that was given was about a person who had primarily medical needs, and then developed some behavioral health needs, and then had to transition out of their setting and to get the services that they needed. And then use care coordination to find services and supports to meet consumer needs and preferences during transitions. Again, here, I think care transitions to help individuals navigate a complex system can certainly be helpful. So I think this is the main message that we want to get across here is keep the consumer front and center, explicitly acknowledge that consumers as the most important group of people for whom the care delivery system exists, improve visibility into consumer experience and voice by prioritizing consumer experience as a body of work across OHA, ensure visibility into consumer experience differences, so that we want to hear from consumers unfiltered voice by race, ethnicity, preferred language, and disability status to advance equity. And then increase OHP consumers in the work to design an inclusive consumer experience strategy. So again, that common message of making sure that OHP consumers are at the table in all of these situations. So that's our last recommendation. Now I'd like to open it to discussion.
Thank you so much, Lavinia, Leslie, and Jackie for your presentation. Looks like John has his hand up. John?
Yeah, thanks, Oscar. I just wanted to say that when I moved over to the Medicaid Advisory Committee, this work was already well underway, and I was just thrilled to see it and hear it, and I support the recommendations. And we've had an education session on it, I think, back in December, and it's been discussed in a variety of different formats. So I'm very interested in hearing what other board members think, and just want to thank Jackie, Leslie, and Lavinia for their presentations this morning. Terrific work.
Thank you, John. Anybody have thoughts or comments on the presentation and or the report? Kirsten, go ahead.
I really appreciated several aspects of this report and kind of the modeling of some of these stories and experiences are, I'm sure, even more heartbreaking to hear by the people who collected them and the people who experienced it. But I really appreciated those, the kind of consumer stories that were interspersed and raising some hard issues about where our system is not working. And I was curious, and I may have missed this in the report, so I apologize if I did. I think the goals and next steps that we are being asked to adopt sound good. I was curious if there were more specific timelines or benchmarks for how we will track our progress in achieving some of them.
I'm happy to take a stab at answering that. So as both Lavinia and Leslie mentioned, there's work underway for several of recommendations. So in areas where we could approach subject matter experts or particular owners of work to collaborate and move that work forward, that work is underway. For some of the areas that are kind of on a higher level, like I think Lavinia's last slide that she covered was this idea to approach consumer experience work from an agency kind of level. Those are going to require, I think, decisions first before we can really move forward on those and provide you with that timeline specific information. Does that help answer your question, Kirsten?
I think that helps. And I guess I would like to say, like, how can we as a board be an ally? Because I imagine setting up new processes and engaging in new methods could be challenging, but are important transitions to make. And so how can we as a board help kind of provide motivation and encouragement around making some of those important transitions as quickly as possible so that those consumer voices really can be centered. And I don't know if this is an annual report. I don't, maybe something like that where we get to hear back on the progress.
Yeah, I appreciate that, and definitely want to hear from Leslie and Lavinia as well. I want to just reiterate that there's a ton of really good consumer engagement work going on and community engagement work going on across the organization. I think what we're asking for is that through your endorsement and support of consumer experience work, again, in general, as a tool for transforming healthcare. The policy board has visibility into a lot of different work that's going on, and I think just increasingly advise us on where we can play a role in helping those other bodies of work.
I believe there was a potential question as well as to how this group can link with other existing committees of the Health Policy Board. I was curious if anybody had more comments on that. As I was reading the report, some of the committees that kind of came to mind for me was the Health Information Technology Oversight Committee, just because of, all the communications and electronic elements involved, and as well like the Health Equity Committee, just because I do think a lot of these are health equity concerns. But I was curious if you could talk more about that sort of the request to sort of collaborate with certain committees.
Yeah, so we presented this work to the Health Equity Committee earlier this year, and I think that was a really great discussion. And I think we're looking for guidance on what that collaboration could look like, right? I think Medicaid Advisory Committee members want to contribute to our overall vision of health system transformation to achieve this member-centered, delivery of high-quality member-centered care. I think we're still at the beginning of how do all of the different committees collaborate, and we are really ready to engage in that conversation. Again, I want to make sure Lavinia and Leslie have a chance to weigh in as well.
This is Lavinia. So I was just thinking about what was asked initially, how can we continue to monitor the progress on some of these recommendations. One, we do plan to continue to have our subcommittee on consumer experience, and that they will continue to collect the information and address some of the issues that we've already highlighted. But I would think that us coming back and reporting at least, maybe biannually, in terms of the status of our recommendations and where we've seen progress, and maybe where we are finding some barriers to that progress might be a first step. The other piece that we talked about at length in our meetings is how do you measure and evaluate progress, right? Some of this is, it's more of a mindset, if you will, keeping the consumer, at the top of your mind whenever you're developing any kind of communication or process or whatever, is something that, that we just have to keep reminding folks to do. Having the consumer at the table could be a very specific activity. You could have a consumer be at least involved in the any of our policy groups, at least there be a representation in those policy groups. I think that would be very, very helpful. We ourselves have said that our consumer experience subcommittee needs to be at least 50% consumers. And of course, we would desire more, but it's consumers and consumer advocates is what is primarily composed of right now. So we would want to make sure we keep that standard up. So those are just my initial thoughts. Leslie, did you have anything to add?
Yes, and to tie into what Lavinia mentioned, measurement of success is going to take it's almost like a paradigm shift by having the consumer at the table and utilizing our other resources. It's going to take us some time to have that measurement of success in a reportable manner. So we are very dedicated to following up and following through with this, so that we do see where we end up in this process. It's not going to be a clear-cut set of metrics as we're all accustomed to. This is going to take a different perspective. And so that's what I would like to just put out there. And thank you.
Thank you. I want to give the opportunity. Oh, Sandy, there we go. Sandy, you have your hands up.
Thank you, Leslie. I have a question for you. So when everything starts changing and the poverty level changes and people are doing the shift from Medicaid to the marketplace, what is the MAC doing? I mean, as far as education or things that would benefit the consumer in the larger picture down the road for easy access to go from one level to the other. How do you guys as a MAC see that? How does it fit into some of the things that you're doing?
Jackie, I'm going to lean on you for this one, because I don't know that I can answer that with the detail that's needed.
Yeah, sure. So the MAC has heard 2 updates now on that work for unwinding the public health emergency and restarting the redeterminations process. And as I mentioned earlier, we have several members who are directly serving on work related to that process. So Lavinia, I think, is being modest. She's actually serving directly on the community partner outreach work group. And I believe the purpose of that group is really to build in those member-centered communication processes to really help make sure that people land with coverage and that they don't become, disenrolled without coverage.
Yeah, the reason why I'm asking, because when we had our retreat, we heard a lot of, there was some disconnect amongst different committees, and how do we bring those resources together for the benefit of the consumer? So that's why I was asking. Thank you.
Yeah, great question. Thank you.
Trilby, before we go to you, I'm going to give the opportunity to Jessica or Ebony to provide any comments on the presentation or the recommendations.
Yeah, the one thing to me, it's when you think about, how do we move forward integrating a consumer driven system that's, consumer centered, to me, I think it's about how do we have the voice from policy to practice. How do we have that representation at all levels? And, and so I guess what I'm trying to say, and I think that, it's, already been highlighted in the conversation, but, it's more than, a client satisfaction survey. It's more than having a specific group, committee, table where you're getting consumer. But to me, it's about, how do you integrate consumers into every facet of the infrastructure and policy process. And so that's just where my mind goes of, besides just looking at how can we get the voice and, feedback, it's, how do we integrate and assure that there's a seat within each piece of the puzzle, if that makes sense. So that's just where my mind's at.
Thanks for that. I think that makes complete sense.
Jessica?
Just a observation and based on some of those first slides is that the way that we manage healthcare is extremely complex, and even our most educated consumers really struggle to gain a basic understanding of what they're being told, why decisions are being made the way they are. And when you look at that, we can work very diligently in bringing that consumer voice, but I think more importantly, it's going to be probably most impactful to try to simplify some of the system. I think it will have a positive impact on our ability to execute. I think it will make it easier for consumers to navigate. I think it will make it easier for healthcare providers to navigate. We have so many layers upon layers of down in the weeds structure here that in some cases can be in conflict with itself. And I think, if we're gonna really try to capture and get the most out of the consumer voice without completely frustrating people, we're gonna have to work on some streamlining of this system.
Thank you, Jessica. Trilby, going back to you.
Thank you, Oscar. I mean, this has been a wonderful conversation, and I just want to express my gratitude again to the MAC for coming forward with this really important information and request. And just to note for the board members, what a beautiful tie-in this will be to an agenda topic that we have later on, where we're doing some debriefing about the retreat. And in particular, really focusing on empowering committees and looking for ways to connect across committees. And having this very specific request in front of us will be very valuable, I think, as we move forward into that discussion and explore what kind of actions the board might want to take. So I just wanted to remind folks that that discussion is coming up, and just note how beautifully timed this is, really hearing the request as one to integrate that consumer perspective. And the committee offering its resources to other committees in terms of bringing that consumer perspective, either as a seat at the table or perhaps as a place to go with questions and opportunities for input. So I think it's wonderful. So just wanted to remind of the process.
Thank you, Trilby. David, any thoughts around this?
I just, when the question came up about what committees to liaison with, I agreed health equity committee is really important. And I think I was there during that presentation. The health equity committee, I think, has changed since that presentation. So would recommend going back and making sure they're updated on a regular basis, because I see there's a really nice synergy and partnership between these two groups.
All right. Well, I definitely saw clear alignment with some of the other conversations we've been having, you know, again, about elevating consumer voice and empowering our committees, and sort of wanting our committees to do more cross-committee collaboration as well. So I'm very supportive of this effort. I don't know if there's any other thoughts, or if Dr. Santa, you're ready to make a motion.
Yeah, thanks, Oscar. I would like to move that the Oregon Health Policy Board support the recommendations of the Medicaid Advisory Committee as it relates to a consumer experience.
I'll go ahead and second that. Is there any other discussion at this point? All right, let's go ahead and vote. All those in favor say aye. Aye.
Aye.
Aye.
Aye.
Anybody opposed? All right, well, that passes unanimously. Thank you so much. Thank you so much again, Leslie and Jackie, for your presentation, and Lavinia as well. Thank you so much for all your work.
Thank you for having us. We appreciate it.
Okay, next we have Ashley Ashworth, Hope Peskin Shepherd, and Susan Otter, OHA staff with the Office of Health Information Technology and the Health Information Technology Oversight Council, who are joining us today to present HITALK updates and its proposed membership slate for OHPB approval. Following their presentation, OHPB members will also be asked to vote on their proposed slate. So I'll go ahead and turn it over to our presenters. Thank you for being here.
Thank you so much. Can you hear me okay?
Yes.
Great. John, I wanted to see if you'd like to open it up as our liaison, if you wanted to make a few comments before we jump in.
Yeah, I would. Gosh, it's great that both of the committees I'm involved in are presenting today. It has just been terrific to be the liaison to HITALK. This is a very, very forward-looking group and a problem-solving group, and a very interactive group. I've been impressed at their meetings that they oftentimes go from large group to small group, and the small group discussions are led by members of the committee and feedback into the large group, and I've just been very impressed with their process and with the diversity in the group, with their interest and support in terms of equity in an area that is so important to equity. So I'm excited about the proposed slate and where they're going, especially in terms of these the community information exchanges, and just a terrific committee that the Oregon Health Policy Board, I think, can be quite proud of. Thanks, Susan.
Great. Thank you, John. So today we're going to be presenting an updated slate for the board to review and make decisions about. This is a follow-up to last year's HITALK slate that was approved by the board in July. At that time, we held seats open because we had additional gaps we were unable to fill with that recruitment. So today we're coming back to propose 4 new members to fill our remaining gaps and complete the committee. In addition, HITALK was called out in 2022 legislation to provide recommendations to the legislature later this year. We want to briefly orient the board to that important work. Get any input from you today. Next slide. So as a quick review, HITALK is the Health IT Oversight Council that was created by the Oregon legislature to ensure that health system transformation efforts are supported by things like electronic health records, health information exchange to connect systems to coordinate care, and other tools and health information technology to support health system transformation and health equity. HITALK reports to the Health Policy Board and has several key responsibilities. HITALK sets Oregon's health IT strategy and identifies and explores and monitors health IT policy. We assess the Oregon's health IT landscape and report on progress and adoption of electronic health records and spread of health information exchange in particular. We also, HITALK oversees the health IT efforts that OHA has. Our major focus currently is updating the HITALK strategic plan for Oregon, which is a 5-year plan laying out strategies to achieve the goals of health system transformation with the support of health IT. Go to the next slide, thanks. There you go. So health IT is foundational infrastructure for health system transformation and health equity. There's a few examples I wanted to give today. Health information exchange supports sharing information to coordinate care across the care team, which can support vulnerable populations, support for sharing information across physical, behavioral, and oral health providers, connecting across hospitals and even over to community-based organizations. As we look at health IT tools and the community information exchange we'll learn about more today, those tools can support addressing social determinants of health by electronically connecting individuals to social services. Sharing information through health information technology can also support public health, emergency response, and individuals transitioning between systems of care. Thinking about our waiver, some of our waiver priorities around transitions of care, including connecting across between jails and the healthcare and behavioral health systems. Health IT tools and analytics can be incredibly important to help providers and CCOs manage populations, identifying risk factors and identifying where interventions are needed, as well as being able to contain costs. And electronic health records and other health IT are important for collecting race, ethnicity, language, and disability, as well as sexual orientation, gender identity data that allows for inequities to be identified and addressed. One thing that came up with that I was thinking about as Jackie and folks were presenting about the MAX work is also the importance of health IT to connect patients to their own data. Most electronic health records today have patient portals that allow patients to access directly their own information and then engage with their providers electronically. So that's also foundational to consumer engagement in folks' own care. Some of the challenges and opportunities we have with health information technology, despite national standards for certified electronic health records, often electronic health records still face difficulties talking with each other. In Oregon, Epic is a predominant electronic health record vendor, but there are over 145 different electronic health record systems in use in Oregon today. Behavioral health providers face unique hurdles. They were mostly left behind by federal incentives that paid Oregon hospitals and physical health providers largely to adopt certified electronic health records and use them in a meaningful way. Behavioral health providers often use outdated electronic health records or are unable to use their electronic health records for all of their functions and often maintain some of their processes on paper. COVID-19 also highlighted the need to connect systems with public health and disparities that folks faced in accessing telehealth services. With health information technology, we see new opportunities, which we'll talk about more today, to connect healthcare to social services, and the importance of data in supporting connecting to value-based care and supporting cost containment. Health IT is a complex space. There's a lot of technical components, and there's also recent federal rules that change the incentives and penalties on providers for sharing information, as well as CCOs and health plans. We also have new federal rules that promote the freedom for individuals to select a patient app on the market and download their information from their electronic health record into the app of their choice. While this is an exciting development, there's a lot of considerations and challenges around patient consent and understanding what's happening with the patient's data through using those apps. And then, as I mentioned before, we have our REAL-D and SOGI standards that are developed in Oregon, and they're Oregon specific, and those are often not implemented in electronic health records. So for providers to be leveraging their electronic health records to collect and store those data, changes are needed to, in working with electronic health record vendors to update those systems. Slide. So as I mentioned, the major focus for HITALK right now is updating the strategic plan. Can you click one more? I think there might be a, there we go. So we're looking towards developing the strategic plan update for the next 5 years. That will focus on these the topics listed here today. We're particularly focusing on electronic health record adoption, where we've made major progress in Oregon, as well as health information exchange, where there's we've made some good progress, but there's more work to go. HITALK has implemented a health information exchange work group that will start meeting later this month, that will dive into some of the technical and federal policy changes that have happened in our environment and identify where there are opportunities to make a difference around. Second major focus area is around social determinants of health and new systems called community information exchanges that are being adopted across Oregon, largely by CCOs in partnership with health systems, community-based organizations. Hope's going to talk after this about the Community Information Exchange Work Group and the legislation that charges HITALK to deliver recommendations on that area to the legislature later this year. Other areas for HITALK in our strategic plan update include patient engagement in health IT, telehealth and broadband, REAL-D and SOGI, and other areas for health equity, and looking at the impact of federal policy changes. So before I turn it over to Hope to talk about community information exchange, and then I'll come back and talk about the slate at the end, I just wanted to mention some of our next steps for HITALK overall. HITALK is engaged in working with its work groups, as I mentioned, and then developing the vision, goals, and assessing the health IT landscape as components of the strategic plan update. HITALK will be closely involved in the legislative recommendations that will be going to the legislature later this year. And then we'll be also engaging both internally and externally around HITALK strategies and concepts, and looking for public comment to HITALK and its work group, in addition to our strategic plan update process will continue into next year. With that, I'd like to turn it over to Hope to talk about community.
Thank you. Hello, I'm Hope Peskin-Shepherd, and I'm here today to talk to you about Community Information Exchange, or CIE, which connects people to resources and services they need. And next slide, please. So this has been a popular topic lately, and here are some of the reasons why. CIE can help support addressing social determinants of health, which is critical to eliminating health inequities. And several things have converged in the past few years that became catalysts for CIE interest and adoption in Oregon. COVID and the wildfires of 2020 highlighted that people need to be connected to services quickly, but there wasn't always an easy way to do that or to know that people had their needs met. There is a need to eliminate barriers between people and the resources and supports they need. Also, OHA established a strategic goal to eliminate health inequities by 2030. And health system transformation has changed expectations with coordinated care organizations, driving them to look at how they can connect to and support the non-clinical needs of patients or members. And now CCOs and health systems are sponsoring CIE platforms in nearly every county across Oregon and partnering with community-based organizations and other partners in these efforts. Next slide, please. So CIE is a network of collaborative partners using a multi-directional technology platform to connect people to the services and supports they need. Partners may include human and social services, healthcare, and other organizations. And technology functions include closed loop referrals, a shared resource directory, and informed consent, and can include other features as well. So what this looks like on the ground is a technology tool that people log into to make referrals between healthcare and social services, and they can hear back and close the loop if the service was received. This allows case managers from CCOs, healthcare clinic staff, and staff at community-based organizations to refer the people they interact with to services and supports, hear back, and coordinate across these different organizations. Next slide, please. Oh, thank you. In the Oregon 2022 legislative session, House Bill 4150 passed, and it requires HITAC with OHA staff support to convene a group or groups with specific representation to explore options to accelerate, support, and improve secure statewide CIEs. And this bill was introduced by Representative Dexter and co-sponsored by 26 additional state legislators. It passed unanimously out of its committees and passed with few nays on the House and Senate floors. This bill sets specific timelines for a draft and a final report on recommendations from HITAC. So HITAC chartered a CIE work group to dive more deeply into this topic and inform the legislative reports. Next slide, please. The CIE work group recently adopted a vision for their work, and that is that all people living in Oregon and their communities have access to community information exchange that creates seamless, trusted, person-centered connections and coordination to meet people's needs, support community capacity, and eliminate silos to achieve health equity. So how can CIE specifically support health equity? The work group members have outlined a number of ways that CIE supports health equity. So CIE can help service providers of all kinds be better connected, which helps all systems of care be more aware of people's needs. This decreases barriers and makes it easier for people to access the services and resources they need. And this also will decrease barriers and improve coordination, which supports a more person-centered and trauma-informed approach and can help prevent the experience of retelling your story. Finally, data could shed light on inequities and inform policy and resource allocation. And not only does this work strongly support health equity, but it can also support the waiver and transitions work and other priority areas such as behavioral health. And CIE is also included as a strategy in the State Health Improvement Plan. The CIE work group is meeting monthly and they started in March. And there is a report due to the legislature in September, a draft report to give legislative recommendations. There are 4 legislative concept areas the group is working on over the next few months. And these high-level concept areas are based on input received from a few partners in 2021, and the work group may modify them as they go. The first area is support for community-based organizations to participate in CIE. This may include grants, technical assistance, education, and other coordination. The second one is the potential for the Oregon Health Authority and the Oregon Department of Human Services to participate in CIE. The third is support for additional OHA and ODHS partners and contractors to participate in CIE. And the fourth is the need for a statewide data program to provide aggregated data analysis and information on requests, provision, and availability of resources throughout the state. So our next steps include community-based organization interviews and a survey led by a health equity consultant to inform the work group and HITAC's legislative reports. The work group will provide CIE recommendations, which will go to HITAC, who will evaluate the recommendations and send the report to the legislature. HITAC's draft report is due in September of this year, and the final report is due in January of 2023. And we plan to bring the draft report to the policy board in the September meeting. Also, public comment can be provided to HITAC and also the CIE work group at any time via email, which we have more information on at the end, or at the meetings themselves. And in addition to the Medicaid Advisory Committee, we also see CIE as a great topic for engagement across other committees like the Public Health Advisory Board and potentially the Health Equity Committee as well. And now I'm going to turn it back over to Susan to talk about HITAC's proposed slate.
Great, thanks, Hope. All right, next slide. So in last year, for the July slate that the policy board recruited or approved, we had a major recruitment effort with an urgent need to fill major vacancies on HITAC. In July, the policy board approved 5 new members, which filled really critical gaps around social determinants of health, oral health, academic and public health, and improved our racial and ethnic diversity. At that time, however, we had significant gaps still remaining, which we'll talk about today. And so we intentionally left seats available for that additional recruitment. This year we did targeted recruitment. We had left our recruitment open as sort of a rolling recruitment open until the gaps were filled. And then we did targeted outreach to identify and recruit specific folks to fill specific gaps. We also found this was an additional opportunity to add consumer representation to HITAC, which we're really excited to do. If you want to click one. So with all of our committee work, we need to do gap analysis to identify the needed areas of representation. So the gap analysis we did, we used the OEI gap analysis tool that was available last year. First, we looked at the statute, which includes the components here in the green bubbles that requires HITAC to include broad representation to collectively have expertise, knowledge, or direct experience in these areas of healthcare delivery, health IT, informatics, and analytics, as well as quality improvement. And those areas are well represented currently. If you want to click one more. We also looked at the charter. Our statute requires a broad mix of individuals and organizations that will be impacted by the work. So we provide more detail in the charter that the policy board has for HITAC. So in blue, the blue bubbles are the additional elements identified in the charter. So we include, for example, healthcare perspectives across providers, health plans, hospitals, CCOs, and users of different EHR and health IT tools. Subject matter experts making up whole person care, so including certainly behavioral health, oral health, et cetera. Consumers and patient and advocates, members with experience in privacy and security, and individuals or organizations that work with populations experiencing systemic inequity, as well as geographic diversity. And then lastly, if you want to click one more, we identified our priority areas for HITAC's work, which included additional representation from around social determinants of health and public health. We also looked at the additional demographic needs that we had for HITAC, given the OEI gap analysis process, as well as identifying health equity, folks with health equity and lived and cross-cultural experience. Slide. So the remaining gaps on HITALK include a gap around behavioral health, a gap related to federally qualified health centers and ideally migrant serving organizations, continuing to improve our racial and ethnic diversity, as well as our health equity, lived and cross-cultural experience. Our consumer representation, increasing that from the current level to an additional, adding an additional member, and then improving our geographic representation. I'll just say we've had long-standing gaps on HITALK around particularly the Hispanic, Latinx demographic representation, as well as behavioral health can be very difficult for us to fill on HITALK. I think in particular due to capacity in the behavioral health system. And it can also be very difficult for us to fill consumer seats. So we were super excited to have an additional consumer. I want to go to the next slide. So these are the 4 additional members that we are proposing we add to HITALK. We're really excited about the slate that it increases our consumer representation. It fills our remaining gaps around behavioral health. It fills the longstanding gap we've had geographically for the coastal region and for our demographic, racial and ethnic diversity. In addition, this adds additional rural members with our rural hospital, that's a non-EPIC hospital. That's often a really important perspective that we need to include on HITALK, and it's often a challenging one to fill. Overall, the strengths of this HITALK slate include addressing all of our statute and charter-defined areas of expertise, as well as 75% of our members have health equity experience. 50% have lived or cross-cultural experience. We have now 3 of our 15 or 16 members that have consumer or advocate perspectives, 3 members from federally qualified health centers. We're one of a handful of the policy boards committees that have a tribal representative. We have social determinants of health and community-based organizations represented, and LGBTQ+ and disability representation as well. Although many of our members are overrepresenting the Portland metro area, many are parts of organizations that support multiple regions or statewide work. So we think this is a really strong slate that balances the gaps that we were prioritizing filling, and will really help us move the needle on our health IT strategic plan work ahead to support health system transformation and health equity. Slide. We do have some additional seats that we expect to open up next year. Our tribal representative is unable to continue, but has had really appreciated his experience on HITALK. So he will roll off mid next year, and a patient advocate representative will also be rolling off. We see opportunities in future recruitments to continue improving HITALK's geographic and ethnic diversity as well. And with that, I will stop there and see what discussion and consideration the policy board has for our presentation. Thanks.
Thank you so much, Susan and Hope, for the presentation. And sounds like we have Dr. Santa working overtime on all these committees. Any questions or comments from the presentation thus far? Or the slate that is also being proposed?
I just want to say I appreciate the effort and kind of sticking with it around trying to really bring forward kind of the priorities and values around consumer representation and just full kind of diversity in representation. And it can be hard and frustrating, and but y'all are sticking with it, and sometimes it's not easy to be the first to try to move things forward. And so I just want to appreciate the intentionality and effort.
Thank you so much.
I have a kind of a very in the weeds question from one of your slides, and then more of a high level question as well. One of your last slides presents the new board member or the new members, and Dave Perkins's location is other. So curious to hear more about that other, what other means. And then on the higher level kind of question, you talked a lot about like your strategic plan work that's currently taking place. And then you also reference, the committee's charter. I'm kind of curious to hear if, as you're looking at your charter, if it's still relevant and it still aligns as we're moving forward to this 2030 goal. Curious to hear about your thoughts about whether any updates need to be made to the charter or if it still is relevant with what you're doing now.
Sure. So Dave Perkins is with Yakima Valley Farm Workers, which is located, their headquarters are located in Washington State, and he resides in Washington State, but they serve, they have multiple clinics that serve various regions in Oregon as well as Southwest Washington. And so, so that's why his location is listed as other. And then in terms of the High Talk Charter, our High Talk Charter was set by the Policy Board, I believe, in 2015, and I think could definitely use another review in terms of our focus on eliminating health inequities. I think we, drive that priority as part of the work that we do as staff and working with a board liaison and the chair and vice chair. But I think it'd be, definitely an appropriate time to look at the charter and identify whether there is additional components that are missing given how far back it was established.
Thank you. John.
Yeah, well, this work is so important. I'm doing some volunteer work in another state, and it has exposed me to how deeply rooted in some health systems barriers to information are. There's folks who really protect health information because it brings them power. And they're very reluctant to share that information with patients, very reluctant to share that information with other systems. And so the work that Susan and Hope have just described is really culture changing and is just, I think, so important. And on an ongoing basis, I think deserves our support and attention. And I think, Oscar, looking at the charter is very appropriate because in the last 7 years, I think everyone has realized how critical interoperability is going to be, how critical easy access to information by patients is going to be. And from a health equity point of view, you can just see how this is the new battleground when it comes to health equity. I do have one issue to just ask that OHA focus on, and that's around seniors. There is at least one senior, I think, on this committee, and there's folks who have expertise around senior issues. But I believe that we could do a better job, and we have emphasized the importance of age when it comes to equity, and of course, seniors are almost certainly going to be 2 or 3 first, because in terms of other cultural issues, they're a very diverse group. With that in mind, I support the slate, and when you're ready, would make a motion that we approve it.
Thank you, John. Jessica or Sandy, any thoughts on the presentation or the slate that is being proposed?
None for me, thank you.
Kirsten or Sandy? All right, let's go ahead and let's go ahead and make a motion. So John, go ahead.
Yeah, I move that the Oregon Health Policy Board accept the high talk slate presented at this session.
I'd like to second the motion.
Any discussion? All right, let's go ahead and all those in favor say aye.
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 Anyone opposed? And any abstentions? All right, so the slate is now approved. Congratulations. Thank you so much for all your work and the wonderful presentation.
Much.
Okay, we are going to take a quick break and we will come back at 10:20 for some public testimony. See you in a few minutes. All right, we'll go ahead and get started again. I hope everybody's back from their break. We're going to move right into public testimony. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with the kind of careful attention, respect, and honor that you deserve. We hold time in our meetings to hear public comments to provide a voice and a perspective from individuals, and those comments are not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and in the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help you keep us on time, we'll start a slide with a 2-minute timer for each presenter. We kindly ask that presenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board leadership and staff to determine the appropriate next steps. Board staff will communicate the next steps with each public speaker. I believe we have, let me see, is it Stick Crosby?
Yes, it is.
Thank you. Go ahead and whenever you're ready.
Thank you, Chair, and other members of the Oregon Health Policy Board. I was just listening in today, and I just wanted to add I really appreciate the high talk presentation and discussion about the work they've been doing with OEI. But as I listened, there was a few things that I just wanted to comment on and hope that the board is thinking about as we talk about these concepts around health equity. And I heard a lot of quotes related to inequities that I think were probably more related to disparities, and making sure that we're aligning with that, and that presenters have that within their toolkit and where they're looking at these different areas and the intersections. I really liked hearing that the OEI gap analysis was used. But then also I heard a lot about including the public and consumers in spaces, which is very important. That's extremely important. But I also want to make sure that when we're doing this, we're not doing a one size fits all type of policy, and that we're really building structural supports for individuals to participate in those spaces, so that dominant culture, values, and opinions are not what's leading those spaces. By not structurally building supports for differences in economic circumstance, racially disparate impacts, barriers in literacy, physical abilities, negative attitudes towards LGBTQ plus folks, the oppression of these groups is going to continue. It's going to continue in these spaces, in these meetings that we hold, and that feedback that we receive there. I really think it's important that we recognize that societal privilege of certain individuals. Even though they may be consumers that are on Medicaid, there's different levels of privilege that they may be experiencing or benefiting in the system that other members are not, and just that we're looking at that critically and considering. That's all I had, was just some observations as a member of the HEC, and would be happy to follow up at any time, but I think we have the structure for that follow-up, and just wanted to, just some key words that I was hearing and some comments that I wanted to put out there to the board.
Thank you, Stick, and thank you for your service on the Health Equity Committee. Is there anybody else who is going to provide public testimony today? I don't think so, so we'll move on to the next item. So I believe we have Sarah Bartleman, the Cost Growth Target Program Manager, and Jeremy Vandehey, OHA Health Policy and Analytics Director, who are going to present the proposed membership slate for the new Cost Growth Target Advisory Committee. Go ahead, Jeremy and Sarah.
Thanks, Chair Rana. Before I kick it over to Sarah, just want to say a couple things. Last month, we held the first public hearing on the 8th for the cost growth target. This was sort of our first entrance into this, into doing public hearings. We don't have the 2021 results yet, but had really great participation from the board, for folks who were invited for testimony, for public comment. Had some great stories from consumers, and just really appreciate the board's work on this. We've had a few fits and starts to get to the first one. I think we'd initially planned the original one before the Delta wave, and have had to keep kind of pushing things out. And I know it's been a bit of a struggle as we're trying to really maintain momentum. And I think it went really well, and just really appreciate the board's engagement, and look forward to the next one later in the year. Sarah's been doing a ton of work on the board membership, and as you recall, was it last month or 2 months ago, went over sort of a straw proposal without names, and really hoping that that we'll be able to move forward today with your feedback or approval. I know a lot of folks are anxious to get the committee working, and I think that's generally a good sign that we're hearing from a lot of folks saying, when's the next meeting, when's the next committee get off the ground. So looking forward to the conversation, and we'll kick it over to Sarah.
Thanks, Jeremy. I have a couple of slides that I'm going to walk through just to recap where we are and present how our proposed committee slate stacks up against the criteria and parameters that the board discussed back in March. There is also a handout in your meeting packet that has the actual slate with everybody's names and organizations. I'm not going to go through that piece in detail, but you do have that as reference. I'm also going to be helped out by Bill in this presentation. Been doing a bunch of work with Bill and Brenda over the last couple months to help prepare all of this and prepare the proposed slate. And so really appreciate, again, that deeper engagement. And Bill, we will make some space for you to make sure I didn't miss anything as we go through the slides. Okay, next slide, please. So just to recap, this has been an ongoing conversation with the policy board for a long time, way back in January 2021, when the implementation committee, the predecessor committee, submitted their recommendations to the legislature. They recommended that there would be a future governance group for the cost growth target program. And that group would be a committee of the policy board. Summer of 2021, the policy board reviewed the draft charter for the advisory committee, began thinking about what the scope and role of that committee would be and how the committee would function with other committees of the board. And then in September of last year, we started recruitment. So we originally launched a pretty straightforward recruitment, kind of the old style business as usual recruitment. And then through iterative conversations with you all, we continue to expand that and try to do a better, more inclusive job with our outreach. We have been working on that for about 6 months, and we were really not sure that we were going to be able to land a proposed slate. And so in March, we came back to you with a proposed committee composition matrix that you approved in March. And that helped us shape the right, help set some expectations for what the right committee composition could be. And one of the reasons we did this step is because, unlike some other committees of the board, this new cost growth target advisory committee is not established in legislation. There is no statute requirement saying there must be 2 seats for CCOs and 3 seats for consumers and 2 seats for hospitals. And some of those similar parameters that we have for other committees, we don't have that this time. And so we needed to create a little structure to help figure out what the right mix would be for this committee. Next. So just to summarize a little bit about what this committee will be doing, they are going to be charged with reviewing and understanding the cost growth trends and cost growth drivers. And it's not just looking at the data, but it's looking at the data to identify opportunities to reduce cost growth. That could lead to recommendations back to the policy board, back to the state agency and other agencies, and possibly to the legislature at some point. So really looking at how do we turn all of this data, reporting transparency into potential action to reduce cost growth. The committee is also charged with exploring opportunities to improve equity, monitoring for negative impacts of the target. Those two are really closely related. There's a whole quality and equity work stream for this program that this committee will continue to have a very strong role in. At some point in the next couple of years, the committee will need to revisit the cost growth target and make sure that what it was set at for the second 5 years of the program is actually an appropriate value. And so we'll have a pretty deep discussion coming up in a few years on that. And then just overall ongoing program implementation, public hearings, reporting, transparency, developing additional accountability mechanisms as the program continues to roll out. All of those pieces would be something that the advisory committee would have the opportunity to inform and advise on as needed. Next. So going back to that ideal committee composition framework in March, what we looked at were 3 different domains. We looked at what the right mix of membership would be across sectors. So thinking about the healthcare industry and non-industry, which is a very broad categorization. We looked at demographics and a number of different factors there, including race, ethnicity, including geography. And then we looked at expertise, and that looked at some specific experience and expertise, things like health economic expertise, but it also looked at lived experience and experience with high healthcare costs and negative impact of healthcare affordability challenges. So I am going to run through the results of our proposed membership slate and how it stacks up against the ideal composition for each of these 3 domains. But before I do that, Bill, Jeremy, is there anything else that you'd want to add for context setting or about the conversation this far?
The other thing I would say is that I think this has been a very thorough and systematic process. So far, you'll see the results of the work that Sarah and the team have done, and appreciate the guidance along the way that the board has provided in terms of establishing the expectations for the composition of the board. So I'll let you take it away, Sarah, for as we go through the details.
All right, thanks, Bill. Next, I think as Chair Rana said earlier, we are asking you for a vote today. So just know that we'll be calling for that at the end of this conversation. Let's go ahead 2 slides, please. All right, so starting with the sector domain, and this is the slide that we corrected. Tara sent out a new draft, an updated slide deck this morning. So apologies if you were looking at the old version, the math did not add up. That was completely my error. So our proposed slate corrected slide does meet all of the proposed ideal composition that we had. We were looking at a 50-50 split between the healthcare industry and non-industry. In this case, non-industry includes our consumer advocates and representatives, as well as our employer purchasers and the research and academic perspective. We have increased the number of consumer advocates and representatives up to 6 as a mix. This is higher than we had before in any previous discussions, and really wanted to call your attention to that, bringing that consumer perspective from a couple of different lenses, both organizationally. So we have a representative from Osberg, representative from SEIU, as well as actual consumers. And then just a reminder that because the cost growth target program affects all of the markets in the state, Medicaid, Medicare, commercial, when we're talking about consumers, we're talking about really anyone in Oregon who has insurance. We're not just thinking about specifically folks on Medicaid as consumers in this case. Any questions about sector?
Sarah, I might just add that this was one of the more challenging. Well, they were all challenging. This was tough to find the right balance, and achieving that balance, determining what the categories were and who fit into what category is nuanced and challenging work. But I think again, Sarah and her team did a great job, not only of identifying folks, but then reaching out and recruiting folks. So this, I'm really pleased to see this balance being achieved, not only across the industry, non-industry, but also within industry. For example, that there's half health plans and half hospitals and providers, large and small. Similarly, on the non-healthcare industry, significant representation from consumers as well as employers and purchasers. So I think this, from my perspective, does achieve the goals that the board had set out.
Well, and I would also thank all of the board members over the last couple months. A number of you have helped with recruitment. You've suggested names, you've helped boost the recruitment requests and application forms out to your contacts and networks. And we really appreciate all of that extra support in this recruitment to bring this slate forward for you today. Dr. Santa.
Yeah, thanks, Sarah. I just want to say, I mean, this slide is a real accomplishment. And I think to have a group of 6 consumers is just terrific. And I'm assuming those 6 will get the appropriate support that they need to understand the issues and talk to each other and all. And I just think from a consumer point of view, this is a real accomplishment, and thank you.
Okay, let's go to our second domain then, demographics. Let's go ahead one more slide, please. So I'm going to walk through a couple of slides and then stop for comment. So we had a number of different demographic factors we were looking at. We do meet or exceed the ideal composition in all groups except for disability status. So I want to call that out as a shortcoming of this slate. And I want to say that the data that we're using for all of this, for all of the demographic information here, comes from the draft or the pilot committee demographic and application forms that we were pilot testing as part of this recruitment. And the disability questions here are 9 questions about self-identified disabilities. I will also say that a number of applicants in our pool left these questions blank. So when I say that we are meeting or exceeding except for disability, that is except for self-represented attested disability. This may be an underrepresentation of the actual pool. It just was not indicated on the pilot forms that we collected. Next slide. We wanted to look at the membership slate by age. So probably, as you might expect, thinking about working adults, we are underrepresenting those ages 25 to 40 and seniors 65 and up. So just calling that out there. Next. We had 2 different ways we wanted to look at geographic representation. So the first was representation outside of the Portland metro area. So we do exceed the goal for representation outside of the Portland metro area. That's the top bar in this chart. And then you can see the breakdown of where all of the applicants in the proposed slate are based. And next, finally, we also wanted to look at experience living or working in rural or frontier areas. And again, we exceed the ideal composition that we had set there. Top bar is the composition, and the 4 bars shaded in gray are the how the slate breaks down. Let's stop there. Any questions or comments about the proposed slate by demographics? Okay, well, let's talk about expertise. Next slide, please. So we had several specific types of expertise that we were looking for. We asked about this in the committee application, and you can see that we are exceeding the ideal composition for everything except health economics. We only have 5% or 1 member of the proposed slate who indicated that they were bringing health economic expertise to the committee. I do want to call your attention to the ensuring equity in policymaking. This is a newer category of expertise. This was not a category of expertise we had in our previous implementation committee. And so really excited to be adding this and calling this out as a perspective for the new committee, and that we have so many applicants in our proposed slate who will be bringing that perspective. I want to talk about the lived experience. There's just a little bit more nuance here. So the pilot application form that we used asked very broadly about lived experience, just sort of said, do you have lived experience? And gave a couple of examples, but that lived experience question did not prompt specifically about lived experience about healthcare affordability or negative impacts of healthcare costs. When we talked about the ideal composition in March, we explicitly clarified that we wanted to when we were talking about lived experience for this committee, we were interested in lived experience with healthcare affordability. So we didn't ask about that specifically, and we didn't go back out and ask all of the applicants in our pool to respond to that question. We sort of added it on as a criteria after the application was already in processing. But we did go back and we reviewed the open text responses that the applicants did provide, and 2 individuals in our proposed slate did share sort of unprompted lived experience around healthcare affordability and healthcare costs. So I want to note that we did meet our proposed composition goal here, but also we didn't collect the data in a way that would let us know if many more members of the proposed slate had this experience and could share this. We could always use this as an icebreaker when we launch the committee and get a little more information on this as we go forward, but I just want to recognize that we didn't quite collect the data in the way that would let us answer this question comprehensively. And then finally, one of the recommendations from the previous implementation committee was that some of the members of the new committee should also have been members of the previous implementation committee, so that we had some continuity of the conversation, so that we had some of that context of those initial policy recommendations that would roll forward and support the committee in this work. And I'm happy to report that 20% of the proposed members in the slate were part of the previous cost growth target implementation committee. And so we'll be bringing that balance forward. And let me stop there. Bill, again, anything else that you want to add or highlight for your fellow board members?
I'll just kick off the discussion here. I'm really interested in hearing what other board members have to say. Again, this is a real challenge, and it's very important to come up with the right composition because there are differing opinions about how to achieve the cost growth targets, and it's so important to have representation, the appropriate representation and perspectives and lived experience on this committee. So this was a real challenge, and again, kudos to Sarah and the team and the board members who helped. Brenda Johnson was also very active behind the scenes working with me and Sarah on this. So I'm very encouraged by the outcome. At one point along the way, I was skeptical we could achieve the balance with the number of board members that we were, advisory committee members we were trying to get. But I think this board does meet. The proposed committee does meet the criteria that the board had set up, and encourage the board to review this and hopefully approve it, but be interested in input from other board members as well.
Thank you, Bill, and thank you, Sarah and Jeremy, for the presentation and for all your work on bringing this slate forward. Comments or questions from other board members? Well, I know that you guys worked on this very hard for a very long time, and you kept coming back and checking in with us and soliciting support as well. So we really appreciate it, how intentional and thoughtful you've been to not just sort of like hurry up and seat a committee, but make sure that you take your time and you are thoughtful about making sure you have the right voices and the right folks at the table. John, you have your hand up.
Yeah, I'll get the discussion going. You know, I think this is a terrific effort, and I support the slate. I do note the challenges with the disabled and with seniors, and you know, I hope OHA is especially taking the senior issue seriously, because seniors care a lot about prices. I think that's obvious. So there are folks out there, we just, for whatever reason, don't appear to be addressing them. I also was surprised about the lived experience. I wonder if the question or language about that fell short in 2 ways. One is maybe the term healthcare, if it would have been followed by a drug affordability, for example, you would have got a different response because, gosh, I mean, it's so common, I think, for folks to be experiencing affordability issues around drugs, and so that surprised me. The other would be, I wonder, I mean, frankly, if some of the healthcare folks, it's a lived experience to see a patient and that patient can't afford the drug you've prescribed. I think all of us who've practiced have had experience with those patients, you prescribe a drug and a patient goes to a pharmacy and calls you and says, "Do you realize how much this costs?" That's a lived experience, and I mean also. It's a lived experience to deny a service on the basis of its expense, or ask that go back to the drawing board and find a less expensive alternative. To really talk to those folks and experience what's going on. At least it was for me, and I know for many other medical folks, when you're on the carrier side, it's traumatizing. But again, as I said before, this is filled with real accomplishments in terms of a membership of this committee, and I support it.
Right, just a quick response, John, to your point about lived experience. I think you're absolutely right. I think almost everyone who's involved in healthcare has at least has that kind of experience. I would call it, we try to distinguish that from patients or consumers, or particularly small business owners who directly out of their own pocketbook had experience with high healthcare costs. There's no question that physicians, other providers, business owners, large and small, health plans struggle with the problem of high costs, and hospital CFOs struggle with the problem of high costs, some of which are more controllable and some which are less controllable. So you're right that almost everyone has at least has some kind of lived experience with the problem of high costs. We did try to distinguish between the different types and ensure that there are at least some people who had directly out of their own pocketbooks had the high costs that had an impact. But appreciate you raising that point.
And I believe I've seen a very specific definition of lived experience in other materials that I've read. So we may want to, I'll definitely want to take a look at that again, but we want to make sure we're clear on what, sort of folks are thinking about as lived experience. I want to see if Sandy or Kirsten, Jessica, do you have any thoughts or comments on the slate?
I don't. I think it looks fine.
I think it represents a lot of hard work, and I'm excited to see what comes next. I did note the kind of one health economics expertise person, which, given all that you were balancing, I think you did a tremendous job. So just put that out there, and I would hope that some of the kind of staffing can help compensate for that particular gap.
Can I speak to that? Because I do want to recognize, and I should have said this in the presentation, one of the changes, I think when we originally started thinking about the committee slate, we originally had the 3 state agency positions as sort of 3 of the 20 seats. And one of those positions is the state economist, Mark McMullen. So he is not counted towards that expertise. What we ended up doing was moving the 3 state agency representatives to ex officio. And so they are not represented in any of the rest of the slate, but they would be tagged in for some of that additional expertise. And I wanted to call that out. Mark McMullen was really helpful and supportive for the original implementation committee, and we would continue to pull in his experience for the new committee.
Thank you for clarifying that, Sarah. Sandy or David or Ebony, any thoughts or comments on the slate?
Simple
I don't have any
congratulations.
comments.
Simple congratulations, and I think you should set a standard for composition of future committees. This approach should set a standard, so well done.
And I think that was Ebony saying she didn't have any more comments. Anything, Sandy, any comments or concerns? Well, and I guess one quick comment I will put out there, I know we talked about, 6 consumers on the committee, consumer advocacy representatives. I looked at the advisory committee and, just about everyone except for one person is connected to some type of an advocacy organization or a system, right? So again, wanting to make sure that we're really clear about, just exactly where we are with consumers. It looks like only one individual is really not tied to any entity. But again, I think you still bring a lot of consumer voice through the advocacy organizations that you're including. So I appreciate that focus. Let's go ahead and Bill, would you like to make a motion?
Sure. I would like to move that the board approve the proposed membership slate for the Cost Growth Target Advisory Committee as presented.
Thank you, Bill. Is there a second?
Second.
All right, we'll give that to Dr. Santa, the second. All those in favor, please say aye. Aye.
Aye.
Aye.
Anybody opposed? And any abstentions? All right, well, it looks like it's unanimously approved. Good work, Sarah and Jeremy. Thank you so much for all your efforts here.
Thank you so much. And I really want to thank the board and recognize all of the board members who either in board meetings or who reached out to share some additional thoughts and really pushed us to improve this process and try something new and get it and work to get it right. So thank you. It felt like a really long time, but I really appreciate the focus and the attention that you've all paid to this. I just wanted to clarify real quick what our next steps will be. So thank you for your vote. We will notify all of the applicants this afternoon. We plan to send an appointment letter to those on the proposed slate and a thank you for your interest. Here's how to stay engaged to those applicants not appointed. We will update our website with the roster. We will reach out and schedule orientation sessions for all of the new members. Some of them are continuing and a majority of them are new. So we want to make sure that we provide that support and orientation. We'll do that later this month. And then we'll get the advisory committee meetings for 2022 on the calendar. So we hope to have the first meeting for the new committee in June, but we'll start working on scheduling with the new membership as soon as possible. And I think that is everything. Thank you so much.
Congratulations, Sarah and Jeremy, on a job well done. And we in the board look forward to working with you as this committee moves forward toward implementation.
Yeah, and thank you, Bill, and also Brenda, who's not here, who helped Sarah kind of put together the final slate. So thank you so much for your service there. Okay, so for the last agenda item, we are going to revisit the retreat that we had last month. Kind of go over some of the themes that we heard from our conversations and make sure that we're in alignment as we move forward with some of these priorities that we want to take on. So I'm going to turn it over to Tara Chetok and Trilby DeYoung to guide some of these thoughts that we've been talking about.
Great. Thanks, Oscar. And Madeline, if you can go ahead and bring up the slides. I'll be walking through some slides today, and these can be found in the meeting materials packet as document number 7.4 for others that are following along outside of the Zoom screen here. So we wanted to take some time to reflect on the annual retreat and to share any new thoughts that may have developed among members, and then revisit a couple areas that we need a little bit more clarity on in order for staff to move those forward. Next slide, please. So we'll take some time looking at the overall retreat themes, and then we'll focus a lot of our discussion today on empowering and supporting our committees. And within that theme, we really want to dive down deeper into a discussion around the Oregon Health Policy Board capacity, continuity and alignment among the board and its committees, and then revisit the recommendations presented to the board by the committee membership work group. And pending time, we can certainly discuss other items related to retreat themes or any follow-up items that members would like to discuss. Since we won't be able to get to all follow-up areas of the retreat today, we did include an action items log in today's meeting materials packet. So that is a detailed list of all of the follow-up items that we are working on for your reference. All right, next slide. Okay, go ahead and go to the next one. Thanks. So when we think back to our 2-day retreat, what you see here on the slide is some of the overall themes that staff have captured to bring forward back to the members. And we just wanted to take some time to confirm with you all that these are in fact retreat themes that stand out, and to also have any discussion if these weren't captured correctly, if there's anything else we want to add. So starting with the first item, supporting the Oregon Health Authority in the hard work to address health inequities and to work on anti-racism. So working together with the agency as one. A theme of continuity and support through transitions. So succession planning with leadership roles on the board, ensuring that there is a smooth transition as we bring on new committees and new members, so that even when we're going through trying times, that the work still continues in a smooth manner. We also heard concerns over the capacity of the board in supporting all of its committees and its committees' work and their statutory requirements. We elevated the importance of relationships. And when we think about relationships, we're looking at board members and committee member relationships across committees, and among the board, as well as relationships with the board and OHA. And we had lifted up the importance of speaking authentically and having courageous conversations with each other and within the spheres of influence that each board member has. And also to identify and directly address health equity resistance and obstacles and take explicit action to address them regardless of the level that they represent or where we feel that we sit. We also talked about the importance of trying out new things, the idea of pilot projects as a way to learn, and using the health equity definition as a way to set a standard and a framework to our work. And that came up again and again as a foundational theme in the retreat. So those are the retreat themes that we've captured. And we wanted to ask members, since the retreat last month, has anything else resonated, or are there any other themes that perhaps need to be represented here that we are not sharing on the screen? Just like to take a moment to gather any feedback from members and make sure that this is correct.
Looks good to me, Tara.
Okay, thanks, Oscar. Okay, I'm not seeing any hands raised, so I guess we'll consider that this is accurate and use that as a reference point moving forward in the slides and today's conversation of the agreed upon themes that we've taken away from the retreat. Okay, Madeline, if you can move to the next slide, please. Oh, you can go back. So now we want to, now that we've talked about some of the overall themes, we want to really dive deeper into a theme that touches many follow-up points that we wanted to discuss with you all today. And that's around how our priority of the board committees. And we had talked about at the retreat to make that priority more action oriented. So we're now using the verbiage empower and support committees. And within empowering and supporting committees, it can feel challenging to fully do that sometimes for the board because of capacity among the current board members. And so we want to have a conversation to determine if there's member interest to support a proposed idea introduced at the retreat around increasing the number of members on the board. The idea there being the more board members that there are, the greater our capacity to serve and support the committees. So just to refresh ourselves on what the statute says about board membership, I'm going to walk through a couple of slides and then we'll have a discussion about this idea proposed at the retreat. So next slide, please. I believe most should know, but I thought it would be a good grounding point just to revisit the board statute around its membership and composition. So within the board, there are 9 appointed positions. You'll see here on the screen, the number 9 is a gray color. And this indicates we'll have a vacancy soon, with this being David Bingsberg's last meeting. So we will currently have 8 members moving forward after today. But within the 9 governor appointed positions on the board, 4 of them are subject to some requirements around income, employment, and benefits. So of the 9 positions, no more than 4 can receive household income from healthcare or a healthcare related field. And also this includes being employed in healthcare or a healthcare related field, and or they can't receive state health plan benefits. So those requirements are tied to 4 of the 9 positions. And when we talk about receive state health plan benefits, we're thinking about the Public Employees Benefit Program and the Oregon Educators Benefit Program, so PEB and OEB. And that impacts a lot of the education system here in Oregon. Next slide, please. So beyond those requirements, when we're looking at the statute for membership and composition, some additional requirements are that members of the board should be United States citizens and Oregon residents, and to the greatest extent possible, represent the various geographic, ethnic, gender, racial, and economic diversity of the state. Additionally, the statute cites that the membership as a whole should collectively offer expertise and knowledge in the areas of consumer advocacy, manage a company that offers health insurance to its employees, public health, finance, organized labor, healthcare, and operation of a small business. So that list that I just read, that is not a shall, those aren't requirements, but that is in the statute of what to strive for in reflection of the board's membership. And next slide. So that's an overview of the board's membership and requirements tied to our 9 governor appointed seats. When we think about the board membership, we heard, actually, let me pause for one moment because I see Sandy has her hand up. Sandy, go ahead.
No, I mean, if there's going to be changes to this, if there's going to be a statute change, we are a little bit more unique as tribal organizations. We've got executive order plus a government to government relationship. So I just want to make sure, I'm really based out of Eastern Oregon. There was nobody on the board. So I just want to relate that Oregon does have an executive order and we are a sovereign nation. So if there's going to be changes, I'm just making a little recommendation there. Thank you.
Well, and just Sandy, to put a finer point on it, we almost certainly would need to engage in government to government consultation with the tribes before proposing a change, right?
Correct. Thank you.
Great, thanks for that, Sandy and Pat. And I think just to ground ourselves in the conversation, I'm just sharing the statute here just as a reminder of the parameters that we're currently working with. And also, we're going to now look at some of the board's committees and the liaison roles. So this is just to give some background and context to the idea proposed around how we empower and support our committees. And one of the ideas to do that was to potentially increase the number of members on the board. So this is just today to have a conversation about people's thoughts, feelings about this proposed idea. So we won't go into specifics about statute changes, but just I think the idea in general and how we work in the interim to fully support and empower the committees. So with the thought that there are 9 positions on the board, we know that the board now has 11 committees. And here on the screen, what we're looking at is a list of the 11 committees of the board and its the current board members that are serving in liaison roles. With David Bingsberg retiring from board service, there now will be a vacancy in the Public Health Advisory Board and Health Equity Committee liaison roles. We've had vacancy in the Primary Care Payment Reform Collaborative, as well as the Health Insurance Marketplace Advisory Committee. And with Kirsten Isaacson transitioning into the vice chair role of the board, we will be looking to also fill the liaison role that she's currently filling with the Metrics and Scoring Committee and the Health Equity Quality Metrics Committee. So just to kind of give a lay of the land there, we know that there's a capacity problem because there's only 9 board members and there's 11 committees. And under the liaison role document that we all reviewed and updated at last year's retreat, we had agreed that all members will serve as a liaison, with the exception that the chair and vice chair are not required to because of their above and beyond duties serving as chairs and planning committees and conducting these monthly meetings. So this is currently where we're working with within the liaison roles of our committees. So we now want to kind of move into a conversation about how do we address some of the capacity issues that we're currently facing. So you can go ahead and move to the next slide, Madeline. And so I'll copy these questions and drop them into the chat so that we can all see each other and discuss these questions together. But some of the questions that we thought may be a good place to start is, what are the opportunities to address the board's capacity? Should the board be larger? And also to consider, are there ways to increase the board's capacity for committee connection without necessarily going through a statute change that may take a little bit of time, considering the legislation session is not till next year. So with that, Madeline, go ahead and take down the slides. I'll drop these questions into the chat, but we just kind of wanted to open this up now to hear from members on your thoughts and guidance on this topic.
Thank you
And of
so
course,
much.
sorry,
Okay.
I was gonna say, of course, Oscar and Trilby, please add in where I missed any details.
Trilby, go ahead.
Just one piece to add, Oscar, is that on the slide where we looked at the gaps in committee liaisons, we do have 2 board members that have not yet taken on committees to liaison with. So that will help. Sandy and Jessica both have not yet connected formally with committees. So just want to put that out there as well.
Thank you, Trilby, and thank you, Tara, for the going over the slides. Yeah, I think capacity on the board is a big concern of mine. You know, we have Brenda, who is going on sabbatical and will be absent for a few months this summer. You know, so our capacity will only continue to diminish, and bringing on new board members takes quite a bit of time because, you know, they have to be governor appointed and a Senate confirmed. So it's quite a process. So we may be, you know, kind of operating with lower capacity for quite a while. So kind of just curious to hear from other people your thoughts and potential solutions to these questions and other comments.
So I'll go. This is Ebony. You know, I feel like, you know, this already happens, but, you know, I think it's, you know, how do we kind of try to keep a continuous queue of applicants like on deck, you know, just because of kind of the robust process and, you know, the timeline that it takes to move someone through that process, in addition to kind of orientation and onboarding and all of that. And so you know, I assume that we probably are always kind of trying to have someone or folks in the queue. You know, I do think that, you know, and I've said this before, you know, I think it's important to, you know, look at, you know, how do we look at, you know, kind of the strategic, you know, priorities and our focus, and then, you know, the relevance of, you know, the current committees, just to make sure that, you know, there's still those through lines as we're, you know, expending capacity. But me personally, and, you know, I know it's a process, but I just feel like there's so many committees and it just requires a lot that I feel like we need a couple more pair of hands. Or I'll just say as you select board members, you know, it really is going to have to be folks that kind of have the time commitment, because, you know, when you're working a full-time job and doing all of this stuff, and then on top of the duties that it takes, you know, to be fully engaged and present in our work and role and responsibilities, it's a lot. And so, you know, I just think it's important to have a process that is sustainable and feasible. So, you know, if possible, you know, one of my recommendations is that we do truly look at trying to expand, and then continuing to look at what's relevant in terms of committees, to look at, you know, if there's committees that we may need to sunset or to pause. And the answer is probably, you know, none. But it's just a lot. And I mean, it's almost you know, for me, it could easily be a half-time job. I could make it a full-time job, but I already have a full-time job. So thanks.
Thank you, Ebony. Sandy, your hand is up.
Oh, I just want to respond to that question. Yeah, I'm ready to jump on board to a committee, but I just don't know what's available and where I would fit best in that in that capacity. So maybe that's something that should be discussed. Tara, we can go through that on a one-on-one. But I've got some national committees I'm on also. So Office of Minority Health, on equity. So, and then on a couple other ones at the national level that I've been appointed to. So, but I'm ready to jump in wherever I need to. I'm all about it.
Thank you so much, Sandy. Appreciate that. How about Bill or Kirsten? John, any thoughts?
I'll just say very briefly that I think this is an issue that needs to be addressed. And I'm somewhat inclined to look at expanding the number of members on the board, but that might not be the best solution. So I think it warrants further discussion. I appreciate the opportunity to discuss it during the retreat, and I hope we can have some further discussions, not only among the board, but also with public input about how we best address this. Because I think it is important to make sure that we're providing the appropriate level of connection to oversight to these various committees. And I do feel like there are gaps there that we need to fill one way or another.
Thank you, Bill. Let's go with John and then Kirsten.
Well, just a couple of random comments. One, I think if we increase the capacity of the board, we should seriously consider doing so in order to add folks who are covered by or taken care of in the work we oversee, i.e. a Medicaid member, a member of the Marketplace Exchange. I think that would be really something to seriously consider. A second is, for myself as a retired person, doing two committees has been reasonable to do, but I am a bit worried that that requirement could be very daunting for somebody who's working. I mean, frankly, I'm so impressed with how much is going on in mental health that I can only imagine how much potentially there is for Ebony to try to figure out, even though she works in the field. I mean, it is daunting. And so I think there should be some flexibility in terms of expectations around a board member, how many committees a board member should be the liaison to when there's such a large effort around behavioral health and all the stuff that's going on there. Third, I think that doing anything in statute means the legislature, and it means the 2023 legislature, and so I keep remembering the comments that were made at the retreat about transition. And I think if we pursue something to change the nature of the Oregon Health Policy Board, we should be prepared for the new governor and the new legislature to say, oh, you guys, yeah, we got ideas about you guys and gals, I'm sorry. And that may be a good thing. But we should be conscious about that. So, those are just random comments.
Thank you, John. Kirsten?
Yeah, I'm really supportive of the comments of several prior board members that have made. So I just just to echo, like, I appreciate the kind of two-tiered approach of like, how do we expand our board capacity and how do we take a look at the committees underneath the board to say, are these charges in the right direction? Are there a meeting cadence in the appropriate and, you know, maximizing the use of time. And so looking about how we both, is there space to shrink demands and also increase capacity? And I wanted to clarify on our board requirements. I do appreciate thoughts raised about if we expand the board, how do we be very deliberate about what we're looking to expand for, not just capacity, but the voices we're bringing to the board so that we can better pursue our goals and mission. But with the requirement, Tara, you mentioned kind of the state health plan restriction that's on there now and how that captures anybody who's receiving PEB and OHPB benefits. I just wanted to make crystal clear that that would not capture anyone who's on OHP.
Yeah, I mean, we've looked into this and asked about before, and it was our understanding that it's PEB and OHPB.
David? Thank you, Kristen. David?
Thank you, Oscar. I also support expanding the board because there's a lot of work to be done. I also want to say that I think the liaison role is working the best it has in terms of my tenure on the board. You know, it's really great to see the board members represent their committees and facilitate that communication between the board and committees. I also want to raise another challenge that hasn't been discussed, which I think is important, and that's the crosstalk between committees. You know, because I was on Health Equity Committee and Public Health Advisory Board, you know, I could inform each committee what the other was doing, and there's a lot of overlap. You know, I've seen John and Kirsten do the same things on the two committees they served. And today we heard really strong connections between Health Equity, Medicaid Advisory, and Health Equity and High Talk. And obviously we don't have enough people for, you know, serving on two committees is a lot of work in addition to the Health Policy Board. And that's not what I'm advocating for. But I would like to encourage y'all to think about other mechanisms to create that cross-talk or cross-communication between committees. And during the retreat, when we had those moving micro mini Zoom sessions where different committee members would come together and learn about what each other is doing, I found a very efficient way to encourage crosstalk between the committees. And if we did that, or if you all did that like once a month, you know, one of the Tuesday educational webinar slots, you know, it would be a very time efficient way for board members and committee members to understand who's working on what and what the synergies are, and when the two committees should get together and unravel an issue.
Thank you, David. Any other thoughts or comments from the board around these questions that are being posed on the chat? Any of the questions? So I think there's more to this presentation. Tara, I think we all started talking about the committees. So let's go ahead and move forward on part 2 of this presentation.
Okay, sounds good. All right, Madeline, we're on slide 10. Okay, I think throughout this conversation and what we've heard today and some of the comments from all the members really aligns. Didn't mean to use that word exactly, but it does align with this next item of continuity and alignment with supporting and empowering our committees. And within this conversation, we want to revisit again some of the ideas that were brought up at the retreat to get a better sense of additional comments and thoughts about moving these forward. So next slide, please. In order to help to continue to cultivate and support relationships between members and staff, And just to create alignment, the idea around perhaps there should be a universal charter for committees of the board. And, we heard today earlier from High Talk that, perhaps it is time for them to update their charter. And we've heard from the Health Equity Committee that they'll be working on updating their charter. And with the landscape over the past couple years, and moving, past a decade of the board being active, is it time for us to consider a new charter template and for this charter to be organized and align committee work with the agency's 2030 goal of eliminating health and equities and focusing on being anti-racist, and also drawing out those connections where there are cross-committee connections, as well as committee work that supports some of the board's priorities. And I think that process could perhaps also speak to some of the comments that were made around what our committees are working on, their relevance, and just overall connection. We also talked at the retreat is we don't really have a process clearly developed on how the board charges its committees with work. We know that the board has authority to ask its committees and charge its committees with work. But how should we define that, and how should we create a process so that there's clear communications and expectations from the board and to committees to have that communication loop active, and also for the board to have a good understanding of the work, the focus, and the current capacity of a committee. And so when we have presentations like we had earlier today from MAC members, we know where committees are at and perhaps where their capacity is to partner and support on new efforts. We talked, another idea around this idea of continuity and alignment was identifying more opportunities for board members and committee members to communicate and collaborate. David just suggested a great idea about utilizing Tuesday planning meeting sessions and educational webinars to host that platform for connection. An idea that perhaps Oscar, you want to discuss a little bit more, either this or the next slide, is around looking at the board's annual retreat. Perhaps the board's annual retreat could take place in the summer, and then when our meetings tend to get a little bit quieter, which I think that is questionable some years, we're perhaps in December and January, utilizing those meetings, time in those meetings to have those member-to-member conversations, or perhaps identify certain months within the year, instead of having a Tuesday, first of the month board meeting, do we all want to attend a committee meeting and participate and show up there? So we were looking for more ideas and thoughts there about how we really identify those opportunities and continue to build on relationships. We've also heard about the need for a board leadership succession plan and identifying those interested in serving on board leadership. And currently, right now, we don't have a defined period. If you're chair or vice chair, how long do you serve? Should we have a time connected to that? And should the succession be that vice chair always goes to chair? And those are some details there that we'd like to discuss with you all today, if there's any set guidance or parameters that members want to lift up. We also heard this idea of providing universal onboarding and training to all new members of the board and committee members. And this is a great idea, and something that the committee membership work group is prioritizing in its guidance document. We're really focusing on not only outreach and recruitment efforts, but retention. And part of this key retention piece really is to provide a comprehensive onboarding and training and ongoing support to all of our members. So that is something that is in the works. But I think these other first 4 bullet points are some things that we'd like to hear more about in a discussion from members today about these ideas and how we move forward on them, and particular guidance or parameters that you would like to see in them. So I'll see if there's any questions before I move on to the next slide, which the next slide is going to tee up some questions around these ideas for discussion. Okay, I don't see any questions. So go ahead, Madeline, you can move to the next slide. Oh, I see a hand is now up. Yes, John?
Yeah, you just, I guess I would add potentially something there. I mean, I've learned through my participation in the Medicaid Advisory Committee how important DHS is to much of what goes on. DHS runs the eligibility system, for example. You know, to some degree, I have a concern. I mean, the most vulnerable folks in COVID are folks in facilities that a DHS oversees. The workforce that is at the bottom in terms of being able to attract folks are the folks working in nursing homes, in group homes, and working for disabled folks. And I don't think we actually think about that when we hear about workforce, because it's a workforce that's related to Oregon Health Authority activities and not to DHS activities. And so when you talk about continuity and alignment, I wonder if a DHS we should listen to and be aware of what's going on at DHS.
Yeah, great. Thank you for that, John. I think that's a great point. Ebony, I see your hands up.
Ebony, we can't hear you.
I think she froze and went away. So she'll make it back to us. But Madeline, if you'd like to go to the next slide, well, we can wait for Ebony to be able to rejoin us. So now we want to move into some discussion around these ideas about empowering and supporting our committees around continuity and alignment. So regarding the universal charter, should there be one? And if so, if you agree with that idea, what should we ensure that it includes or addresses? And then in regards to, how the Oregon Health Policy Board assigns its committees or charges its committees with work, are there thoughts, ideas on what that process looks like? Additional thoughts or ideas that anyone would like to share on some of the ideas we raised about how to create more intentional time for member collaboration and communication with committees. And then also thoughts, guidance and parameters on what should be included in a succession plan for board leadership. So those will be some of the questions we'd like to hear from members now, these next several minutes. And I see And I'll drop these into the chat, and I see that Ebony was able to rejoin. Ebony, I believe you had your hand raised and had a question or a comment to make. Okay, I see someone else's hand is up. Oh, Sandy, go ahead, Sandy. Oh, I guess Ebony is back. So let's go to Ebony and then Sandy.
Ebony, you're on mute.
Ah, okay, can everyone hear me now?
Yes.
Okay, sorry, I've been having the worst connectivity issues today. I was just, a simple, very kind of straightforward recommendation is that I know that, the state in general, has a number of policy boards and committees. And so, one recommendation is, maybe also I'd be interested in maybe understanding what other boards and committees do around just kind of communication, the feedback loop process. And so that's just one suggestion. I'm happy to kind of share some recommendations offline. I would serve 2 terms on the Oregon Board of Social Work. And so, there's some things that we were doing there that might work here, but, I think how do we leverage, some processes that other boards and committees already have in place from other areas within the scope of the state of Oregon.
Thank you, Ebony. Before we go to Sandy, I just want to provide a little bit more context and clarity around this universal charter idea, because I think that might have been that's probably one of my ideas. First, I want to make sure that it would be each committee would continue to have its own charter as they stand. It wouldn't be about getting rid of all of them and just having one. It would be more about creating, whether it's a charter, we call it a charter, or we call it a guiding document. It doesn't, but we really need to give all the committees like 2 or 3 priorities to make sure that their work is sort of in alignment with these priorities, right? Like that the board is sort of can identify whatever those priorities would be. Like one that comes to mind is like, collaborate with each other, right? Work with each other, make sure that you're aware of what the others are working on, so that you're working on like sort of parallel tracks or together. Again, the other one could be potentially trying to make sure that their actions that they're working on, whether it's their strategic plan or their work plan, aligns with the agency's 2030 goal, right? So again, I just wanted to provide a little bit more clarity about this universal charter. Doesn't have to be like, that's not what we need to call it, but it's more about giving all the committees 2 or 3 priority like items that they should all be working towards. Sandy.
Oh, I was just trying to get clarification on that, because it was like, we're looking at universal healthcare. How are we going to meet those objectives in some of the larger plan that's been going on for quite some time? And then, I remember the days when DHS was part of OHA. Now we've got the marketplace underneath this umbrella of the Oregon Health Policy Board. So when you're looking at health equity and how you're going to get there by 2030, you've got to have something that's going to identify where you're going to be by that date. And you've got House bills, legislative agendas that you have to meet. So I guess I'm just kind of curious how you can form a group to address those needs.
Thank you, Sandy. One of the things we want to do is, get a little bit more feedback from the board on some of these questions before we get into the how. And once we have a little bit more clarity and direction from the rest of the board members, we, board leadership and staff can sort of work out more of these, like how we get there. Kirsten.
I really appreciate your clarification around, or your additional details about the universal charter, Oscar, because I think my mind was assuming a different direction, was like, I don't know about that. So I do like the simplicity of what you're outlining. And I think that could I would want to pair that with kind of the communication loop that Tara, you outlined that I think we need to, and I'm sorry that I don't have suggestions on how to do this, but I think we need to make sure that communication loop is full circle between the board and the committees, because I also heard loud and clear at the retreat that some committees felt like we've got all this direction from the legislature, we got all this direction from the board, and we can't meet all of it. And so want to make sure that our committees feel heard and like they are tasked, that their capacity is matched with their expectations. And then I did have one other comment. I know that you said the trainings are underway, and that wasn't a question that you're presenting to us, but I just did want to flag that I appreciate that those are happening. I think they're needed. I actually think special attention needs to be given to people in chair and vice chair roles, not special attention, but specific training so that the way the meetings are led can facilitate retention and voices being heard. And I think that's different than, it's a special role that has additional influence.
Thank you, Kirsten. Bill.
Just a few comments on these questions. I agree that some kind of universal charter, or at least a template for use by the committees makes sense. I think anything that clarifies the role of each committee, but also its relationship to the board itself, and of course to any underlying legislation that creates these committees is very important. And so I think there needs to be both improved consistency and improved clarification for a number of these charters. They shouldn't have to start with a blank sheet of paper each time. I want to just kind of reinforce the point that Kirsten just made about providing additional support to committee chairs and co-chairs and the roles they play and the tools that they need to be effective leaders. I would broaden that a little bit to other committee members. I'm thinking particularly of the Cost Growth Target Advisory Committee that we just, the slate that we just approved. As I think Sarah mentioned and John Sant also mentioned, there are a number of new folks coming onto that committee who may have not had experience in these kinds of committees or deep expertise on some of these issues around costs. Now, some folks do have that expertise. The CFOs from the health systems and the health plans, a number of the employer groups may have expertise, but particularly the consumer representatives may need some additional help. And I think it would be important to have maybe a systematic approach to supporting committee members to make sure they're fully, not like kind of onboarded, but up to and understand the role of the committee, but also are provided with the necessary content, background, and information, and ongoing support as issues come up so they can participate fully. Just the last thing I'll say is that we should all be really thankful for everyone who participates on these committees. For most of them, it's in addition to their day job, and sometimes their day job, whether it's paid or not, takes up a lot of time. So their willingness to participate in these committees is a real service to the public in general and to the state. And we want to make sure they're provided with all the support that they deserve so they can be as effective as possible and express our appreciation for the great work that they're doing.
Thank you, Bill. David, any thoughts on these questions?
Other than the right questions, and I look forward to following your progress as one of the public.
Great. Any other comments or thoughts on these questions or the questions before regarding OHPB capacity or the committees and how we can support them better? All right, let's go ahead and introduce the next set of slides. Tara.
All right, so we're on slide 13, Madeline, and this is a follow-up to the committee membership work group's presentation on day one of the retreat. And we were running tight on time, and I'm not even sure if, we had the presentation slide up at this point, but they did share these recommendations with the board on next steps, and they really align around the member survey. And the recommendations include that the board would officially adopt the member survey, and it would be completed by, go ahead to the next slide, Madeline. The recommendations around the member survey would be that all new members joining the board and committees of the board would complete the member survey. And this is because currently within the board and underneath the board, there's different committees that have executive membership requirements. So they have a different application process than other committees that have their membership appointed by the board versus the OHA director. And so this would create alignment. So all new members are answering the same questions. We're collecting real D and SOGI data on all of our members that are used in the OEI gap analysis tool and help us to understand the representation and the strengths and weaknesses and opportunities within composition of not only individual committees and boards, but overall membership of the board with its committees. So that would be to adopt the member survey, as well as then staff of the committees when they're considering filling vacancies, that they would be using the results from the member survey in the gaps analysis tool, which then informs where there's opportunities to strengthen composition within the committee or board, and that would help focus the recruitment efforts of that group. The second part of the recommendations would be that an annual update would be provided to all members if they want to complete their survey again. So over time, people's responses to the questions could change. So there would be an opportunity to update that. And then annually, the group would provide an update to the board on the membership composition and the data. So those are the recommendations from the committee membership work group. And I wanted us to revisit this because, again, it was rushed, and wanted to see if there is support from members for these recommendations. The next slide is really just some resources for reference and on the work group's materials. And I did include a link to the member survey if anyone wants to refresh themselves on what the survey questions include. And that was also included in the meeting materials packet today, but we can go ahead and take down the slide. So I wanted to see if members have questions or comments on these recommendations from the committee membership work group.
Thank you, Tara. I personally don't have any concerns and am fully supportive of this. I know this was guidance. We stood up this group I think maybe almost 2 years ago, and it became a very high priority to be able to make sure that our committees are representative of the entire state, geographically, lived experience, health equity experience, lots of different backgrounds. So I'm fully supportive of this. I'd love to hear, John, what are your thoughts?
Yeah, I would just ask, it was helpful for me to see which committee members hadn't filled out the survey, the Medicaid Advisory Committee. And I thought, oh, well, I'll get that solved. And I contacted them and they were all, oh yeah, I'll do this, I'll do this. But then some of them didn't, so for me, I would kind of appreciate ongoing information about who hasn't filled out their survey, and the chance to let them know that this is important for us, and it's important feedback for us, and just try to figure out, why is that? Just without getting into details, I was surprised who didn't fill it out. So anyway, I would just mention that I wouldn't expect anybody else, any other liaisons to do that. But again, in my case, I have the time and would like to do that.
Thank you, John. Any other thoughts or comments? I also know that Brenda was very engaged, and I believe Ebony as well, in sort of the survey. And I believe Susan was leading this work. So I want to just thank all of you for your participation and your great work in this area. Tara, are we formally like making a motion and recommending a vote at this point?
Yeah, so I think that would be the idea, so that it's formally adopted by the board and we can reference this vote to show that this is a requirement of new members going forward, that when they're being considered to be added to committee, that we are capturing this information so that we really have alignment across all of our committees and we're moving in the same direction together.
Okay, thank you. So any other comments or questions from any board member before we make a motion?
Looks like Sandy has raised her hand.
Sandy, go ahead.
So I guess I just need a little clarity on what guidance and perimeters should be included in an OHP leadership succession planning. So are you looking down the road? I know you mentioned, Tara, should the chair be or the next vice chair be the chair? Should there be limits on how long you can be a chairperson? So is that, if we're going to vote on this, then who's going to provide the guiding documents for, yes, we should, no, we shouldn't? Is there another committee that's actually participating in this? Or, you've got 3 different things.
Yeah.
You sign 3 different committees to work on each one, so that we're, sometimes it can be productive if you try to do too many things at once or spread it out to the board. So I'm just curious. So yeah. I don't know who the committee is, so I'm trying to get.
Yeah, I think this is a lesson learned from me. Like, I've probably shared too much information and requests for feedback towards the end of a long meeting. So that's on me. But what the vote on right now is not the succession plan, but just the member survey. that you'll recall that you completed that. It has the Real D and SOGI questions, and it asks about lived expertise, cross-cultural expertise. And so what we're hoping to do is have that be an interest form that all new members are completing of the board and its committees, because right now there's different interest forms that committees and boards use. So we'd like to create alignment there. So the vote would be around adopting the survey by the committees, and then the board receiving an annual update, as well as members have an annual opportunity to re-complete their survey if any of their responses have changed. And then I think perhaps with the succession plan and some of the other items, it might be best if I work with the chairs to develop some draft documents and then bring those back for review and considerations once there's some content there to respond to.
What I would recommend, because I could see how for newer board members, the membership survey and this vote can be a little bit confusing. What I can recommend is, why don't we go ahead and hold the vote until next meeting? And that'll also give us an opportunity to have Brenda back, as well as Jessica. So it sounds like for the most part, folks are in support of this. We'll get, some clarification for Sandy between now and the next board meeting, in addition to just even the committee assignment. So why don't we go ahead and hold this vote until next month? We already took plenty of votes today with no need to do another one. So I feel like we approved lots of different things, and we did a lot of great work. So why don't we go ahead and end the meeting a few minutes early? I want to thank OHA leadership and OHA staff for all your wonderful work putting together today's meeting. And I want to thank all my fellow board members for your time and your service to this work. And obviously all the committee members that are participating in this work. So we will see you next month, Tuesday, June 7th, for our next board meeting. So have a good rest of the day, everyone. Thank you.
Thank you.